to our meeting this morning. Just a reminder that we will be taking a hard break sometime around noonish, depending on where we are at on the agenda. If we're in the middle of an item, we'll just gauge it by that. And I will acknowledge that the City of Hamilton is situated upon the traditional territory of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. The land is covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and Quebec to share and care for the resources around the Great Lakes. Further acknowledge that this land is covered by the Between the Lakes Purchase 1792 between the Crown and the Mississauga of the Credit First Nation. Today, the City of Hamilton is home to many Indigenous people from across Turtle Island, and we recognize that we must do more to learn about the rich history of this land so that we can better understand our roles and residents, neighbors, partners, and caretakers. And members of the public advise that our meetings are webcast live by the City of Hamilton and temporarily archived on the city's website. And as well, a reminder that all of our electronic devices, other than our computers and tablets and headsets, are to be on a non-audible function during our council. I'll now turn to a roll call, and I'll start with Councillor Wilson. Please indicate your presence.
Present.
Thank you. Councillor Farr.
Here.
Thank you. Councillor Nan.
Here, present. Thank you.
Ula.
Present.
Thank you. Councillor Jackson.
Present.
Councillor Collins. Councillor Pauls.
I am here.
Thank you. Councillor Danko.
Present.
Councillor Partridge.
I'm present, and Mr. Mayor, I do need to take a phone call between 10 and 10:30 just to give everyone a heads up. Thank you.
Thank you. Councillor Whitehead. Councillor Vanderbeek. Still getting herself rebooted, I think. Councillor Ferguson.
Present.
Thank you. Councillor Johnson.
I'm here.
Thank you. Councillor Pearson.
Present.
And Councillor Clark.
I am here, sir.
Thank you. I will probably roll back. You can probably indicate by virtue of those that are logged in a little later their presence as well. And Madam Clerk, I can ask you if there's any changes to the agenda.
Yes, Mr. Mayor, good morning. There are two added communication items. There's two items of correspondence and support for Councillor Farr's motion this morning. There are 9 added written delegations calling for the continuity of the bike share in Hamilton to be received and referred to consideration of item 5.4, the public bike share transit contract. And item 5.2, a written delegation from Tim Potacek on behalf of the arts community in full support of the Community Enrichment Fund applicants. There is one added discussion item for the public bike share transit contract update, a staff report. There is one motion being withdrawn, Councillor Marula's motion establishing a LaSalle Park acquisition task force. There are 2 added notices of motion. Councillor Marula is replacing his one that is being withdrawn with a future of LaSalle Park motion. There is one interim continuation of the SOBI bike share program as well for Councillor Nan. There's one change to the private confidential matter. Item 9.2 is now listed as follows. Appendix A to report PED 20109A, public bike share transit contract update, wards 1, 2, 3, 4, 5, and 13. There are 4 added bylaws, a bylaw being to permanently close a portion of Fletcher Avenue, and there are 3 bylaws to permanently close portions of the road allowance of Harrison Road. There are 2 changes to the order of the items. 5.4 bike share transit contract update, and also the interim continuation of the SOBI bike share program. These are going to be considered and voted on after the council rises from closed session. That is all.
Okay, thank you. Please indicate Councillor Collins is present. I see him on the screen. So for the meeting, I don't see any other changes on that. May I have a motion to approve the agenda as amended? Is that a motion or a question, Councillor Johnson? Yep.
Yep. Thank you. Just a heads up, please. I have a Fletcher Road in my ward, so I'd appreciate it if we ever have any things like closure of a certain street. We actually put the ward behind it, so I don't get a rush of emails coming at me. So I just wanted to put it out there. I had 2 Jones Roads. I had 2 Glover Roads. Now I'm hearing another Fletcher. So I just want to make sure that my residents are understand this is not the Fletcher Road in Glenbrook. Thank you.
Okay, thank you. Any
Yes.
other?
Yes, Mr. Mayor, this is for Ward 5, Fletcher Road
Right.
in Ward 5.
Super.
Correct.
Thank you.
Okay. Any other comments on that? Let me just get rid of this. Not seeing any. So a motion to approve the agenda as amended, moved by Pauls, seconded by Pearson. All in favor? Electronic vote. And I'm going to assume that's carried. Sorry. Councillor Farr, you're okay? Thumbs up from Councillor Farr. Ferguson, not voted yet? Thumbs up, Lloyd? Yep, okay, thank you. Not present as yet. Thank you, that's carried. Any declarations of interest? Okay, seeing none. I have the minutes of the City Council meeting May 20th. May I have a motion to approve those minutes, please? Sorry, Lloyd? Okay. Go ahead, Councillor Ferguson.
Yeah, I tried to click the microphone to declare a conflict of interest and it rejected me because it said that item wasn't up yet. But I do have a conflict on item 4.8 of correspondence. This deals for a letter from the taxi industry where I'm an investor.
Okay, thank you. Any other conflicts, councillors? I'm not seeing any. Anyone indicate a conflict? No. All right, so we're back to the minutes of May the 20th, 2020. Mover and a seconder, please. Moved by Partridge, seconded by Farr. All in favor? Electronically. And I'm going to assume again that that will be approved. Any votes that you need to get? Sorry? Councillor Vanderbeek is not yet on.
I'm back.
All right, that's carried. Thank you. And a motion communications, Councillor Collins, please, to get it on the floor. Go ahead.
It's moved by myself and seconded by Councillor Marula that the May 27, 2020 Council communications be approved, amended.
Thank you. And so we have communications items 4.1 through to 4.10. Any comments or questions on it or any of those? Councillor Partridge, go ahead.
Yes, thank you, Mr. Mayor. It's a process question more than anything. 4.2 from the Home Builders Association. We dealt with this on the last agenda at our last meeting, May the 20th, and I thought we received it then. And I'm wondering why it's back on the agenda.
Good. Madam Clerk.
Just to inform council through the mayor that this item was actually not on the agenda. It was discussed on the agenda. Clerks had received it the morning of, so we were unable for council to formally receive it on the record. That's why it's
Okay.
here today.
Thank you.
Okay, thank you. Councillor Collins on the communications, go ahead. Well, I've got Councillor Collins first, and I'll get to Councillor Jackson for sure. Councillor Collins.
Yep, thank you. On 4.8, I was hoping that we could refer the correspondence to staff and for some consultation and then get a report back in terms of what options the city might have. I know a lot of industries have been hit very hard, obviously, by the current situation. And taxis specifically, it's the double whammy with the insurance. And then, of course, what's going on now in the industry with the loss of business. So I would move, seconded by Councillor Jackson, that it be referred to staff for consultation and report back.
Okay, we'll make that change. If there's no objection, we'll just build that into the overall approval. So thank you for that. Councillor Jackson, same issue? No, you're good? Okay. Any other comments on communications? Councillor Pearson, go ahead.
Thank you, and I want to thank Councillor Collins for putting that forward, because that was what I was going to ask, is that we could have a report back, because the industry is getting hammered. And I have a number of service providers in Ward 10, and certainly am very concerned, because I think their rates are about $14,000, $15,000 a month right now, which is absolutely ludicrous. And then, you know, we also set the rate of what they have at the meters, what they take at the meters. So it's a double whammy for them right now. So I want to thank Councillor Collins and Councillor Jackson for moving that forward, because I would also have done that. Thank you.
Okay, thank you. I recall that Councillor Ferguson declared an interest in that specific item. How do we separate that out? Do we just have him recorded as opposed to, or abstaining from that item only? He can vote on the balance of the communications. You'll split it? Okay, thank you. Councillor Partridge? Yep.
Yes, thank you, Mr. Mayor. I tried to click on the microphone the second time and it said it wasn't in session yet. Just on item 4.4 with Michael Power, he's president of Independent Living, and his concern about the minor variance for Committee of Adjustment and his request for virtual meetings. And at the last council meeting, again, May 20th, we did vote to open up virtual meetings for Committee of Adjustment. And I'm just wondering if who will be in touch with him as far as this arranging those, giving the schedule of when those Committee of Adjustment meetings will be on.
It would be my understanding that everyone that has a backlog of issues going to the committee will be informed as to when the official start date is for that committee. So I don't know that that's been defined as yet. Madam Clerk, is there anything specific on when and if they're going to meet as a Committee of Adjustment?
Through the mayor, we are going to be reporting back. Sorry, planning staff are reporting back next week on the continuation of public meetings, and within that, any decision that council provides, we will be notifying all of the applicants to let them know how and when Committee of Adjustment will be continuing, as well as other planning matters. So I'll work with the Director of Planning on that.
So thank you, and I do appreciate that, because you know, certainly the Committee of Adjustment it's a very busy committee, and there are minor variances that are piling up. A couple of them are affecting my ward as well. So I do appreciate that answer, and if we can get back to those folks expeditiously, that would be much appreciated. Thank you.
Thank you. My understanding is there's like 100 items that are in part of the backlog. So hopefully we can get to them sooner rather than later.
Yep.
Thank you. On the communications, any other comments, questions, concerns? If not, we'll go to a vote on communications as a whole, with Councillor Ferguson indicated as abstained on the taxi industry. Councillor Ferguson, we need your vote. Or a thumbs
I
up.
did. I abstained.
Okay.
Is that the right thing to do when it's just one correspondence item? I want clerks to give me advice on that.
Yeah, you can vote on the communications as a whole. They're going to actually identify you as abstaining on that specific issue.
So I should click yes rather than abstain then?
Correct.
Okay, I'll change
Yes,
that.
please.
Okay.
Thank you. Thank you, and that's carried. And we're going to go to Councillor Collins for a motion on moving into Committee of the Whole. Councillor Collins.
Yeah, it's moved by myself, seconded by Councillor Marula, that council move into Committee of the Whole.
Thank you. All in favor? And indicate that Councillor Vanderbeek is present. Thank you, and that's carried. And we're going to go to public hearings and delegations, and the number of delegations to a number of issues that we're going to be dealing with later in the agenda. So could I have a motion to receive and refer items 5.2A and A1 and 5.2B to the consideration of their respective items on the agenda? So we're dealing with those later. So Is that a motion or an indication? Do you want to speak? Motion. Thank you, Councillor Farr, seconded by Councillor Vanderbeek. Any other comments? Councillor Danko? Go ahead.
Also, item 5.2AG, I believe, should be also referred with the same item for the SOBI discussion.
Yeah, that was the added item. Yeah, fair
Okay,
enough.
sorry,
Yep.
I didn't hear that.
All items related to SOBI and to what's the other one? The arts community enrichment fund application will be referred to the respective items. All in favor of that? It was moved and seconded by Farr and Vanderbeek. Carried, thank you. And we're going to turn to item 5.3, Public Health Services Post-Peak Framework. Turn it over to Dr. Elizabeth Richardson and Jason Morgenstern, providing Committee of the Whole with a presentation on the good work that they've been doing and where we're going from here. Dr. Elizabeth, floor is yours.
Good morning, Mr. Mayor.
morning.
It's good to be back. If you'll indulge me for a minute, I'll get this up and running and try and get it so it's working for everybody. I think I did one step in the wrong direction. 1 second. Screen 2. Andrea, how am I doing? Have you got the presentation there? Because now I can't see the Zoom meeting.
Not at this time. We don't have it. If you go to the share
Yeah, I did that.
and then
Should
share
have
content,
share screen 2, which is
and you
where
should
I'm
be
going to do
selecting
it.
your presentation. Is your presentation already open?
It's open, but then I have to go into presentation mode.
Yes.
Yeah, okay, you should be seeing that screen now. I can see it on mine, so when I get there, we should be good.
Yes, and then if you just minimize,
There we go.
you'll see me if you just minimize that little screen.
So you should have you now, correct?
We have you Public Health Services Post-Peak Framework presentation to City Council on the screen.
Awesome, great.
All right.
That's the right part. All right, well, it is very good to be back with Council. It's been many months now since I've been able to be with you and to talk with you and to get your counsel and advice, and I'm very glad to be back. I do want to just take a couple of minutes to acknowledge a few things. One is the amazing work that my public health colleagues have been doing, along with all of our colleagues in the city and those across the broader health sector. We've been at this since the end of January when we started in partial activation and then moved into full activation in February. We've had up to 267 of our 454 public health workers assigned to working on COVID-19. It's been incredible, the teamwork, and we'll talk a little bit more about that as we go through the presentation. And of course, we've been fortunate to have up to about 37 of our city colleagues, and then we had to call on a number of them again just when we were entering all the long-term care home data out of the testing that happened there. We had to enter 20,000 results, which is usually about a year's worth of work, and we got it done thanks to our colleagues in about 10 days. So just amazing work that is going on. And of course, the remainder of the staff are continuing to keep going with the essential services, everything from making sure our food premises that are open and running are doing the things that they need to do to keep people healthy, working still with new families who are welcoming children into a world that is very different than they anticipated. Mental health services for children and adults, addiction services, all of those things that are going on while we're continuing to learn to do business in new and different ways. And of course, that's what today is all about how do we move forward in new and different ways here in the city as a corporation, but also in our broader community in the province, the world, as we learn to live with a world with COVID-19 in it as well. It's been a really, really good work working with Paul, of course, at the EOC and all of our colleagues there. We've done several emergencies over the years, or I have it'll be 25 years actually in August that I've been with the city. And this has been one of the best coordinated, and of course, the most extended events that we've dealt with. And the work and the collaboration, the collegial spirit across the whole group is just fantastic. Since I've been away for so long, I hope you'll indulge me a little bit in letting me go a little bit long with my presentation today, because there's a lot to catch up on with you. And of course, COVID is anything but simple as we go forward. And so I want to make sure, I could have thrown about 100 slides up here to try and catch up on where we were. And of course, as we resume going forward with the Board of Health, I'll catch you up on many of the other details as we go, and looking forward to that too. For this particular presentation, we've had a group of residents who've been working with us. Jason Morgenstern, who's on the line, is one of them, and he's really been the one heading up this particular presentation, but as well, he's had input from his resident colleagues. Joanne Kieran, who you may have heard about, has worked with us in the past, and I know the mayor's seen her presentation around thoughts about what we could continue to do as we move forward. Also, Adele and several of my other colleagues have helped to provide input and polish and reflect along with our colleagues across the health system. We do have a Health Services Emergency Management Committee that meets on a 3 times a week basis that incorporates the hospitals, long-term care, primary care, and so they've helped us to polish all of this up. So it's definitely been a group effort, and I get to be the one to present it to you today. Just to, again, that journey that we've been on, the first case in Ontario was actually detected on January 25th. It took a little while for it to reach here in Hamilton. Our first case was March 11th. So it's just been about 2.5 months that we've been actually managing cases and outbreaks here in Hamilton. That was the same day that the WHO declared this to be a pandemic, acknowledging that this was a new virus that was spreading globally and going to continue to do so. And our first death, unfortunately, also happened on that day in Ontario. We saw our schools close on the 12th, recognizing the severity, the seriousness of what was happening, and the desire to limit spread. And we had our first community acquired case here in Hamilton on March the 13th. And of course, those community acquired cases are very important because they mean that we're not able to follow those chains of transmission as we're looking at cases. And so there's spread going on that people aren't aware of. And that's either because people aren't following the measures that need to be done, or there's some other aspect to the virus. And of course, this is when we started to learn about the role of pre-symptomatic spread, i.e. before you got sick, you were actually quite infectious, and in some cases, some asymptomatic spread. And I'll talk about that some more too. We opened our first assessment center here in Hamilton, March the 16th, building on the really good work that was done back in H1N1 with a cooperative approach amongst hospitals, primary care, public health. And so that served us well again this year. And you know that we have 3 assessment centers that are currently up and running and are busier than ever following the further expansion of testing this past weekend. The provincial emergency came about on the 17th, and our border was closed to non-essential travel, which of course it remains today. And our first outbreak was declared at a long-term care facility on March the 21st. We had then our first death on March the 24th, going into mandatory self-quarantine for travelers here in Canada on the 25th. Testing began to become expanded again, and you know that testing had been initially quite restricted to those who were who traveled to the country who had compatible symptoms or were the contact of a case. And we knew that testing was really a very important part from experience around the globe, and that we needed to see if we could get that testing expanded. And so initially we were restricted by the number of sites who could do it in terms of labs being able to run it, and the number of reagents, because it turns out those have been in short supply around the world. They've been looking to do that. The swabs have been in short supply. Some of them are made actually in the parts of Italy that were under lockdown. So eventually we were able to get that open. Of course, it's continued to be broadened since then. Drive-through testing started up at the Dave Andrewchuk Arena on April the 17th. So we've been at that for about a month and a half. And then we began the process of doing the mass testing in long-term care homes on April 22nd. Of course, those have been a very significant concern for us because of both the fact that that is where a number of people who are very vulnerable to the virus, those over 65, those with chronic illness, are housed, but also that in any congregate setting, you have people living very closely together, and especially where they need care. And there's that more of that close, regular contact between caregiver and the resident. They're very concerning to us in terms of the ability to spread. So that began for us to understand really what was going on there. And you've seen a number of very small outbreaks because only 1 or 2 residents or staff were infected related to that mass testing. But at the same time, it was really good news because it was only 1 or 2. And so you could see that the control measures that have been put in place in general, the masking of all workers in long-term care homes, the closing to all but essential visitors, all of the things that have been done and worked very hard at in long-term care homes, including our own two, Wentworth and Macassa, who've gone through their own process related to COVID-19, has helped to limit that spread. The framework for reopening our province came out on April 27th, and we started to see certain businesses and workplaces reopen on May 4th. Knew our schools were going to stay closed till the end of the year on May 19th. And then, of course, we've been looking at how do we move forward further in terms of reopening. This is a very busy slide. There'll be lots of busy slides today, and we'll delve more into these as we go. But this has really been, you see the dotted line, which has been the experience with the virus. And essentially, we talk about peak 1, which is what we have just gone through and experienced, and then moving into this post-peak phase, which is what we're choosing to call it here in Hamilton. As we prepare for what comes next. And that dotted line of number of cases, we're hoping doesn't go back up, but of course that's all up to all of us and what we do as we go forward about whether or not there'll be a second peak. You can see all of the work that has been going on. So all of these green items here are all the plans that we have developed and implemented within public health, often in cooperation with the whole EOC. When you look at things like vulnerable populations, and looking at enhanced surveillance and how we can do that, you'll see that there's been a lot of work done in order to manage and help to maintain not only the community's health related to COVID-19, but of course for vulnerable populations to minimize the health equity impacts and to minimize the impacts in terms of mental health and well-being. And learning, as we've had to do these last few days, how to do things differently. Heat-related illness, like thank goodness that our health protection group and our healthy environments group and our group at the EOC have been on it, and we're with Chris Herstick at identifying places because we have to open that up far sooner than we actually thought we would. But this is where we've tried to be ahead of the game, tried to look forward and say, what are the things we need to do as we go forward? You'll see in orange then are some of those ones that we're just implementing, including our ethical framework. And so very much ethics, human rights, vulnerable populations have been at the core of what we're considering as we move forward. You'll also see here that we're trying to figure out how to run public health services as we go forward. We've had a lot of people working very long hours, and some people working those for 12 days straight, where they're working 12, 14 hours a day. And of course, that's not sustainable at all in the long term. And so we've looked very closely at what we can do as an organization to make sure we're supporting people in their work. Some of the stories that they're hearing, some of the places that they're working with, they're having very difficult times. And so making sure there's ability for people to debrief, access to resources like EFAP, but also very careful and conscious scheduling of work and making sure we have enough people in place. I will say at the management level, that's been very challenging. We have a very tight, very effective management team, but when you're trying to work essentially a 14 to 15 hour day, 7 days a week, there's not enough of us to do that work and to not result in these very long days and hours, and as well the potential for burnout amongst the group. So we're looking at how do we move forward? How do we go into a new structure so that we can live in this COVID-19 world where we're going to continue to provide IMS support to things like the Roslyn and like significant changes in direction that we see from the province as they're trying to figure out how we should all move forward, but also continue to open back up some of our business, the very important work that is done that goes far beyond COVID-19. And we'll be coming back to you in June to talk a little bit more about that, and then a little bit more in July as well about what is council's preference about how some of those things go forward. So we're going to go through some of those other elements as I go forward. I won't spend any more time on this slide, but it gives you a good idea about what we've been working on over this time, in addition to managing the outbreaks and the cases. So moving beyond the first peak, as we chose to call it, we do think in looking at the epidemiology, and I'll give you a little bit more about this in June, but when you look at the number of cases, you've seen the number of cases rise and then begin to plateau, and particularly here in Hamilton, where we're seeing under 10 cases per day, new cases per day. And that's good news for us. But we are still seeing cases. And as we move forward, we're going to be doing, making sure we're following that closely. So, as we were trying to understand this virus and as we moved forward, essentially we threw the book at it globally. And especially here in Ontario, we did everything we could to stop the spread. So school closures, business closures, avoiding gatherings, case and contact isolation and quarantine, travel bans, our hygiene practices, our IPAC, all of those things were put together to try and stop transmission, reduce transmission, and get a hold on this so that we didn't end up in the same places that the same problems that places such as Italy and Spain did. You've heard a lot about modeling, and you've never seen until today us actually put forward what Jason Morgenstern has done with the modeling, because it's been a bit tricky, both because of the number of cases is smaller here in Hamilton. And so whenever you have small numbers, small shifts can make things look very different. But we've also been developing and consuming the approaches that have been done by others, and so had consistently been updating and updating and updating. And so this is the first time you're actually seeing it here on a graph. But what we did was do something very similar to what the province did, but displayed it a little bit differently, and looking at the projected number of cases based on experience in other countries and the kinds of measures that were put in place here in Ontario. And so the low was if we'd had an experience that was more like somewhere like Taiwan or Hong Kong or South Korea. The high was, if we had an experience more like Italy or Spain, and the middle was sort of more the average experience that we're having here in Ontario. And you can see we're sort of tracking along that middle level of experience with our actual number of cases and flattening that curve. And this hasn't been updated in the last week or so, but you would continue to see that curve flattening as we go forward. Extensive physical distancing, though, which has been an absolute hallmark of this, and we're very careful, as you all know, to not call it social distancing, because social connection is absolutely essential to us as human beings, and social connection has been so important to continue in all the ways that we have. But physical distancing still comes with a cost. We've seen the loss of 3 million jobs in Canada already, and an increase in our unemployment rate to 13%. As a result of businesses closing and even temporary closures. And we know from other events that when these sorts of things happen, when you have this kind of unemployment, and then on top of it, you have the lack of connection that comes with physical distancing, that suicide risks can increase by 20 to 30%. And indeed, we have seen, we're tracking some of the mental health statistics here for Hamilton, and we have seen increases in urgent emergency department visits for mental health, particularly in the last couple of weeks. Substance use has also been associated with this, and we've had warnings from at the Canadian level about substance use and seeing consumption when measured on a larger basis going up. And that's concerning, of course, as well. And then we do know, again, from other experiences, such as what happened with SARS, that the complications of chronic diseases such as diabetes and hypertension can also increase. And part of that is because people are fearful and they stay away from healthcare. And we've heard talk about that. And, over the last couple of weeks, the mayor's been very careful to highlight that and the importance of going still to see your primary care physician, going to the hospital if you have, any signs of chest pain or early signs of stroke, that is really important to do, and that our health system is quite well prepared to minimize any risk of transmission while being able to provide care, whether it's virtually in the case of your family doctor, if you're wanting to go over where your blood sugars are at and how your diabetes is in terms of its control, or whether you do see those early signs of a heart attack or of a stroke and need to get to the emerge department. And unfortunately, we do see that the most vulnerable is disproportionately impacted in these situations. And we're seeing that in terms of the studies that have been done out of the US and elsewhere. We've been talking about collecting race and income data here in Hamilton, and Toronto, Peel, and London had gone ahead and started that process. The province about a month ago had said they were going to pick that up and look at collecting it systematically across the province. But of course, they've been busy with many, many things and supporting the economy to reopen. And so Last week, we decided we would go ahead using those same tools that have been used there, and we began collecting that data. I believe it was yesterday on cases here, so that we do have information. We'll be able to do that analysis going forward. So our current success, that flattening of the curve, has been based on all of those things that have been done. But we have what some people call the pandemic paradox: is the better we are at staying safe, as people say, and not getting infected, the more of us are still vulnerable to the infection. And so because we've done such a good job, we estimate that only about 2.5% of us have actually acquired immunity at this point. And so we need to make sure that we keep it so that one infected person doesn't cause, ideally causes less than, on average, one additional infected person for this outbreak not to continue to grow. And so we need to figure out which of the particular measures that we're doing are the most important ones as we go forward, so that we can maintain the control, but begin to open the economy back up, experience the economic benefits of doing that, and the other benefits of people being out and being in contact, although still 6 feet apart. So we're going to talk about a little bit more about what that looks like. So one of the great things about having Joanne and Jason is that they have been able to keep in touch with the literature from around the globe, and they've been bringing that all back to us in the Public Health Services Emergency Control Group and helping us learn about what's worked and what hasn't. And so what you see here is the experience from across a number of different countries: China, South Korea, Japan, Singapore. And we've talked about this second wave and whether or not this second wave is inevitable. And this helps to tell us that perhaps not. And so we want to understand, for those countries who may have had a first wave, like South Korea and China, but have managed not to have second waves, or even those like Taiwan and Hong Kong, who've really managed to keep it ramped down all the way through. What are the key factors? What are the key things that they are doing from all those measures that are making the biggest difference in terms of moving forward? So some of those, two of them that really stand out, are, of course, Taiwan and Hong Kong, and they've never had the degree of distancing measures that we've had, and yet they've been quite successful. So one of the ways that some people refer to this, you may have heard us talk about it before, is the hammer and the dance. So the very hard close down, and you saw this particularly in China, and we've done some of that here in Ontario in terms of restricting things. And then the dance is letting them open up and try to maintain that distance and the hygiene measures and all of those sorts of things so that we don't get spread. And it is Taiwan and Hong Kong who have never stopped dancing. They have been doing that dance all the way through, rather than having that hard spread. South Korea, where you see that big peak, they had what some people call a super spreader event. I know some people don't like that term, but if you depersonalize it, it's not about the individual. It is about the fact that there was extensive spread that happened related to a particular event that related to unfortunately, to a church congregation in South Korea, and who had a church that had a large number of members, and then had a spread that went on from there. So their focus has largely been in Daegu, but their control otherwise has been pretty successful. So going again through in detail, what were the key things that they did in Hong Kong, Taiwan, and South Korea? So one is intensive testing and case and contact management. So going out, finding the disease, making sure everybody who's symptomatic gets tested, rapidly identifying cases so that they're tested within 24 hours of becoming symptomatic, and then following up cases and contacts very quickly thereafter have been absolutely key to what they've done. They've also put in place some centralized isolation and treatment. So most of their treatment happens in the community. For mild to moderately severe cases, they don't go to hospital. They stay in the community. They're looked after by community primary care. And as well, there are isolation facilities that are offered. So some of the spread that we see in Hamilton in particular is amongst families. It can be very difficult to isolate when you're living in a house together. And so they have had facilities where people can go and spend the time while they're ill, that are specialized isolation facilities, and then go back once they are well. You can imagine, though, with some of the things that we're talking about, the need to be at home for long periods of time, then or things like centralized isolation, those can be really challenging. And so for some people, those aren't things they want to pursue. So it is also part of the dance we're doing with people, is understanding how can we help them to take those measures and stay in isolation as we go forward. So we'll talk more about that. We've talked a lot about mask wearing, and the Public Health Agency of Canada, Theresa Tam, came out to talk about mask wearing, well over a month ago now, and it's been recommended for some time. And you've heard Ontario dig deeper into that recommendation more recently as we've been talking about opening up. So the good news is that mask wearing does make a difference. What it makes a difference in most of all is preventing spread. And so if somebody is ill and doesn't know it yet, it prevents them from spreading that to others. It does provide some protection for a well person from everybody else, but its main job is to prevent people who don't yet know that they're sick and who are out and about from spreading that virus. It's very interesting. In South Korea, 98% of people sometimes, and 64% always wear a mask when they're outside. And we'll talk more about the hierarchy of controls, but those have been that's been really key, and they have not had the same highly restrictive measures. Singapore and Japan, who you saw initially, did not have in place their widespread testing and case and contact management, but they and so they seem to have had a higher number of cases. And as you can see throughout, these have not had those widespread business closures. So it does suggest we need to step up our game in some areas to compensate for the decrease in physical distancing that will come as we start to go out and about and do our business again, whether it's going back to work or it's going to stores to do the things that we need to do, or it's figuring out ways to do other things like how to have religious services, how to do the things that are just normal parts of our lives in new ways. But case and contact isolation and quarantine, strengthening both institutions and business in their infection prevention and control, which is what IPAC stands for, and their hygiene practices, all of our hygiene practices are going to be absolutely key. So some people have called this next phase de-escalation, which seems to imply that we're going to come out of this and we're going to go back and we're going to do things that we always did. But no, we've been in training for the last 2.5 months about how we're going to need to live life differently. And we need to continue that training, perhaps implement it in new ways as we go forward. But we're going to need to continue to live out the changes that we've made as we go forward. So we talk about this more as reorienting our public health measures as we go forward. So as you can see here, in those different dimensions in testing, contact tracing, widespread physical distancing, what we have been doing, what primary care has been doing, they have been here in Hamilton doing a lot of community management, doing a lot of virtual care. Our hospitals have been cohorting patients within the hospitals and delaying elective services, but those have to get back. We have people with knees and hips that need to be done. We have other procedures that need to move forward. And in congregate settings, of course, we've been managing outbreaks, but we need to figure out how to live this new reality in those settings as well. So what could we be doing? What did we look at that was working? What limited those? What barriers were there as we go forward? So our objectives in this time point are to continue to prevent or reduce the trajectory of wave 2, ideally prevent it altogether through reorienting our public health measures in this new reality. We want to continue to minimize the illness and deaths from COVID, but also from non-COVID causes of the other things such as mental health impacts, the other impacts on chronic diseases, the impacts from the standpoint of income and worsening of the social determinants of health as we know have been happening. We want to minimize the potential negative health impact of the response, as I've said, and to support Hamilton in resuming both social and economic functioning, but in a safe and new manner, and ultimately to protect the most vulnerable. So the key components post-peak are sort of illustrated in these 5 groupings. So around communications and engagement, we've been doing a lot of internal and external outreach. And there's some things we want to add in bold in each of these. So just those components are communications and engagement, safe reopening of business, continuing to do our epidemiology and our surveillance, our testing, case management, and contact tracing, and of course, working hard to protect those who are most at risk. So as I said, we've been doing our both internal and external outreach, a lot of work with our partners and stakeholders, and looking at ideas and input into our response as we've gone forward. But continuing to build on supporting alignment of the public health messaging into neighboring regions as well, so that we're having consistent messages as much as possible. And so you'll see there's been a lot of discussions amongst the medical officers about how we can do that and ensure consistency. Safe reopening of businesses, so supporting the city and business community in assessing and mitigating risk to reopening, and strengthening IPAC in order to minimize that risk through things like community mask wearing, and providing input to inform our provincial guidance as we have done along the way. We continue to monitor and report on outcomes, analyze for clusters and community transmission, tracker how we're doing, but we want to get better with a dashboard to track our progress and be providing that to information on that to yourselves as well, and monitoring triggers around when can we relax or increase restrictions. And this is part of the dance we're going to need to do as we go forward. In testing, we've seen a increase in asymptomatic testing, but particularly of those symptomatic individuals, right as soon as they possibly can, to have them in so they can be isolated as we go forward. Rapid case and contact management, and exploring those options for voluntary centralized isolation for those who are amenable to it, and continuing to protect those most at risk. So here, this is all science and all evidence about COVID-19 is preliminary. As you know, we've only known this virus for about 5 months now, 5 or 6 months since it emerged in China. But it is one of the coronaviruses, but it is different. It has its own characteristics, and we're trying to learn about them and share globally information and analyze it as quickly as possible so we can understand it. So this is what we understand today around modeling about when transmission actually happens. So that left axis is the number of new infections caused each day, and when we see spread in the course of time. And so we think about 45% of infections happen from carriers before they actually develop symptoms. So they're pre-symptomatic. They're asymptomatic at the moment, but they're going to become symptomatic. And so we think about 45% of new infections happen during that time period. About 40% happen once somebody is actually symptomatic. And then smaller contributions either from the environment. So that means when somebody has coughed or sneezed and or been rubbing their nose and mouth and touched a door handle, or somebody's touched the table where there've been droplets, and then that person in turn has then rubbed their eyes or rubbed their nose, and they've gotten the infection that way. So environment plays a role, but it tends to be a small role in this. And then finally, the asymptomatic infections, these are people who never develop symptoms at all. We think probably about 5%. So for sure, as we're looking at this, the two major drivers of transmission are the people who are sick and those just before they got sick. And so that's where we want to get in and do the controls. And that's why intensive case management with those who are symptomatic. So having them tested as soon as they know that they're symptomatic, and then getting in and making sure that they're isolated and have all the supports that they need to be isolated from others, but also then talking to all of their contacts and then finding the people who could be pre-symptomatic so that we can effectively isolate them and make sure that they aren't spreading to other people as well. So that's why case and contact management are so very, very important. So there's 7 recommendations in total, and the first 3 of these that we have are to encourage individuals with any COVID-19 symptoms to present for testing within 24 hours of symptom onset. And so we've seen as we've gone through in managing cases, initially people came forward quite early, and then, when we didn't have a lot of tests available, and when the messaging became, look, if you're sick, stay home, isolate yourselves, they weren't necessarily, and even the provincial tool that was online, because of the lack of testing capacity, it said just if you're sick, stay home and don't go out. But we're really encouraging anybody with symptoms to go and get that testing done within 24 hours of symptom onset. We know for some people it can be a concern because then they're going to have to isolate, they're going to have to do the things that they need to do. And so we need to find ways to support them as the recommendation 3 is for both their cases and for their contacts and families to support them during isolation and quarantine. And of course, the second recommendation there is to make sure we have full capacity for intensive and timely case and contact management. Some key metrics to think about as we go forward are these ones here. We're working very much on these. We just had a presentation from Carolyn Hero, who's been working with our epidemiologists, and we've also been reflecting on these again with our health sector partners about what do we need to understand about going forward. So we need to understand metrics around virus spread and containment, both the daily number of cases we have, but as well the cases that can't be traced to another case. So right now here in Ontario, about 2/3 of cases overall are community spread, as we call it, or can't be traced back to another case. Here in Hamilton, it's a very different scenario. So we have only about 26% of cases that can't be traced to another case because our both our numbers are smaller than some of the larger municipalities where they have larger numbers of cases, but also we've been able to do the work to trace people back. And we had started up with testing of asymptomatic contacts probably about 2 weeks ago now to try and find all of those cases that we can and make sure that they're isolating and then not able to spread the virus. The other thing is the incident cases associated with institutions, the number of long-term care outbreaks, those sorts of things. So by no means is this a comprehensive list at this point. We'll be coming back to you with that, but these are the kinds of measures. Healthcare system capacity is absolutely crucial as well. So what is the overall hospital capacity? Because we know if there is a second wave that we need to be able to have the healthcare available to people, including critical care and ventilators. We know that those are essential as we go forward. And so there is a whole plan for reopening that the hospitals put together and they've had us look at with them. And it's going to continue to be a dance about making sure the capacity is there. Unfortunately, we have had to use some of that capacity as well for things like what happened with the Roslyn, where there had to be decanting of a facility. And so it is the hospitals to date that have taken up and been able to support those individuals when they're unable to be cared for in their own homes. PPE availability is also very key, both for reopening, but also especially for our healthcare system. And we talk about it over and over again, the importance of continuing to maintain the medical masks, the medical grade supplies for our healthcare system. And a lot of good work being done across the country and here in Hamilton as well to reorient our business, several of our businesses to producing this PPE. But it's still in critical levels for some things such as gowns. And so we need to continue to monitor that as we go forward. And as well, our public health system capacity. So if we want to detect those cases within 1 to 2 days of symptom onset, we do need that that testing capacity. We need to make sure we preserve some of that capacity. So it's not just for those who are asymptomatic, but also for those who are sick and we need to get results very quickly. We need to get them in and tested and results quickly. We want that less than 24 hours from case detection to isolation and contact tracing. And again, once we reach those, find out the cases, the contacts of the cases, to be able to get to those contacts within 24 hours as well. So those are all key metrics. And so they'll be essential to track as we go forward. So I've talked a little bit about contact tracing for COVID-19 and how important it is, just to give you some sense of the investment it takes. And I know there's been a lot of discussion about apps and those sorts of things, and apps have a place in terms of getting information, and that's important, and it can help to streamline the process. But relationships, as we know, are absolutely key, and in answering questions, in helping people to understand the importance of what it is that we're talking about. And I would continue to say that nothing replaces the personal phone call, the personal contact with these individuals as we go forward. So when we were going through the peak, we averaged about 12 daily cases. Now, of course, some days were much more than that. We had the occasional 0 or 1s in the middle of the peak. And that required 80 staff for case and contact management and monitoring. So that was for the initial contact of a case, and each case had anywhere from 3 to 26 contacts that we would then have to contact as well. And then we would follow both the cases and contacts over the next couple of weeks until they were cleared. Either the contact hadn't developed any illness or the case had cleared sufficiently that they could be removed from isolation. And so that's why there's so many staff involved in that process. And that's not for outbreak management. Outbreak management has been done by a separate team who are dedicated to managing the cases and contacts for those outbreaks. So as you can see, it's involved significant redeployment when we talk about the 267 of 454 public health staff that have been redeployed and the reductions in service that we've had as a result. So right now we're averaging about 4 non-outbreak daily cases, and that, along with those, again, 3 to 26 contacts, takes about 64 staff members. Now that is starting to include some of the work we've been doing with a few of the outbreaks, but clearly that's not sustainable with reopening our public health business. And so as we look at the businesses that we need to get back to, in order to provide good service, public health services to Hamilton, we need to talk about what is it we're going to do, what's our approach as we go forward. And so we'll start talking about that more in June and then July. If we want to detect 5 times more cases, and I always use the analogy of the iceberg. So whatever disease we're managing, there's the cases that we know about, and there's the cases that we don't know about. And we want to find more of that iceberg in order to reduce transmission. So if we want to get 5 times more cases than we have right now to get back up to 20, it requires at least 133 staff to be focused on that. We know some of our colleagues have been helping through med students, as Middlesex London was able to do. We know that Public Health Ontario has been assisting in some ways. Whenever we've looked at those, it hasn't worked out well for us. We're not able to gain as much as we might, as some other health units might, where they really do need to offload some of those pieces, but we'll continue to look at and collaborate with others to look at how we do it and bring that back to you, as I said, in the next month or so. So more case and context management staff is going to be essential as we move forward. On the out-of-home isolation, as I said earlier, this has been the in-home transmission has absolutely been a driver in terms of our number of cases. So about 2 out of 3 cases are related to infection in the home. And so providing an out-of-home isolation option is a strategy that has been used in some places. And so we're looking at what that might mean here in Hamilton. Sorry, I'll come back to that in just a minute in terms of what we pursued there. So our recommendation 4 and 5 are to continue highlighting the importance of physical distancing, hand hygiene, and respiratory etiquette. And I must have said this at least 100 times just in the last week or so about how, as we move forward, these things are going to continue to be the backbone of what we do. So physical distancing will be washing our hands often, washing them when we come back in after getting groceries, using hand sanitizer if we need to while we're out, but remembering that hand washing is just as good or better. Our respiratory etiquette, coughing into our sleeve, staying home if you're sick at all, those all need to be there as the backbone of it. And then the mask wearing in the community is, of course, another piece. And I'll just come back to give you a little bit of an illustration about that. So we know, just freezing for a sec. We know that when somebody sneezes or coughs, that these droplets, and this is how COVID-19 is spread, it's through these droplets. It's not little tiny aerosols, which is what does happen with some viruses, and that's why you need the N95 mask. It is more these droplets. They're bigger, and so they can't travel very far, and they fall to the ground. And unless you're doing what's called an aerosol generating procedure, really those droplets are going to fall, and they're not going to transmit outside that 6-foot range. And so we know these are emitted not just with coughing and sneezing, but also when we talk. And the louder we talk, with singing and those sorts of things, the more of those droplets are emitted and the faster they come. So the overall larger number of droplets that are transmitted. So we can reduce that with masks. So this is it's a bit of a complicated diagram, but essentially what you're looking at along this left axis here is how many people are wearing a mask. So 100% is everybody, 20% is not very many, nobody down in the corner. And how good is that mask at catching the droplets as we speak. And so if it's 100%, it's awesome. It catches nearly everything. You know, we're out here at the 100% mark. If nobody, it's not catching anything, really, it's just letting everything go through, then it's really of no effect. And the nature of that cloth mask is really important. And so, you know, loosely woven fabrics like a lot of scarves or that sort of thing, they don't do much in terms of stopping those droplets. Things really can get right through. But it turns out if you just use 2 layers of a tightly woven fabric, something like bed sheets or T-shirts that are tightly woven, those two layers are actually very good. So how effective does a mask have to be and how many people have to wear it? So you see these bars are essentially back to that how many people are infected per case. And if we have a mask that's about 60% effective and about 60% of people are wearing them, it looks like that's enough to control the epidemic, to get to the point where it's not just continuing on, but starts to die out as we go forward. So the color represents that transmission rate. So yellow means it's still transmitting a high rate. If you get out to this blue, it means your transmission rate is really falling off. So when we're talking about cloth masks, those continue to be very effective. So the other thing we talk about is, and this is our 6th recommendation, is utilizing a risk-based approach to guide the safe reopening of businesses and workplaces. So we talk about how modifiable is that work to reduce the risk. And we talk about 2 factors that are really important to modify. So one is the number of contacts, so the number of people in the setting at the same time. And the second is the contact intensity. So that's, you know, how close are people? How long are people in there? And so that intensity can be low or it can be high. And it's very different depending on the type of workplace or business that we're in. So things that increase contact intensity are these sorts of things. So being in an enclosed space, so that's going to those droplets aren't going, you know, elsewhere. They're held within the room. So the size of the room is important. How long you visit for. So if it's quick pop in and out, that's great. But if you're there for long periods of time, that's going to increase your intensity. The amount of UV light exposure is important. So we know UV light kills the virus. So if you are outside, if you are out in a garden center, it's better than being inside in an enclosed business. The ability to maintain 6 feet of separation. So all those arrows that we see when we go out and people staying back, that is really, really important. But if you're in a place where people aren't able to do that, that increases the intensity. What do you do while you're there? So the amount that you talk, and if you're yelling and singing, and you think nightclubs here, and we've seen this in other parts of the world as they started to open up, they started to have nightclub-based outbreaks because there people are tightly together, yelling, singing as they go. And so those are things that increase the intensity. How often are you touching surfaces? So if you're able to keep your hands to yourself, maybe just touch your buggy as you're going through the grocery store, as opposed to having to open a lot of different doors, touch different surfaces, pick up things that other people are picking up as well, then that's going to increase the intensity. And of course, if you're facing each other, that is, as opposed to being able to stand away from each other, that is a factor too. Ventilation, of course, is an issue. And it can work in 2 ways. So ventilation overall of moving air and moving the virus away is important. But there have been a few examples where ventilation is strongly blowing air in one direction for people who are staying in one place for a long time. And then it can just blow droplets from somebody who's infected. So thinking about ventilation and how it works is really important too. So then as well, the number of contacts. What are both the absolute number of people who are in the place, but also the number of unique visitors over time entails greater risk. So somebody who just has a few people come in versus something like a coffee shop or a bank where people are going through constantly are going to have more risk. And then the average proportion of the group that's infected will be higher with the higher number of contacts. So that's why it's a greater risk. So this kind of lays out a few common venues like an outdoor park. What are the things that make it higher risk? Well, not much. It does pretty well on a lot of those things. And how could you decrease the risk in those settings? Well, you can usually maintain your physical distancing unless you're in Trinity Bellwoods and choosing not to do that. There's nothing enclosed there. You've got good UV light exposure, so it's a pretty good place to be. A grocery store, well, tends to be more enclosed. You have for staff, they're seeing a lot of people and they have prolonged exposure to one another. It can be at times difficult to maintain physical distancing. But if it's a big store, you know, and this is where we talk about some of the big box stores, and the customers are only in there for a short time. It's something where, you know, most people are out on their own, or they're at most talking to the one person close to them or asking a question. They're not yelling and singing. So it's, you know, in a better place. An indoor restaurant, though, especially smaller ones where you can't physically distance, you've got longer periods of contact for both the customers and the staff. They're generally there, you know, conversing while they're having dinner. They may be yelling, laughing, speaking. They're facing one another. Then you're going to have this higher risk, and you may have very limited ability to choose factors that decrease it. So if you were to just locate those, you can see, you know, things that are indoors, like museums, but don't generally have a lot of people in contact with one another. They have some risks, but not as high. But those fast food, malls, sit-down restaurants, gyms, they tend to have both higher risk from an indoor perspective and the level of contacts, while parks, you know, things like self-storage places. So this is where choosing what to open when is really important. And this is that hierarchy of controls that you've heard us talk about. So this is a concept from occupational health and safety that's been developed many years ago, well, you know, well founded. And it really talks about how there's the ability to remove exposure is the best way to control things. And then if you can't remove that altogether, so what other controls can you put in place to try and manage that exposure as you move down to that tip, down to PPE? So oftentimes people jump right into this personal protective equipment. Well, I need a mask, you know, I need gowns, I need those sorts of things. Well, you know, one of the things that works really, really well is working from home, because then you're physically distanced. You don't need any PPE. You don't need any of those things. And so if you look at something like a fast food restaurant, you know, physical distancing has meant that many of them have remained closed in terms of seated business, but drive-through has been okay. If they were to come in and still have takeout inside, adding floor markings to encourage that distancing and manage flow, minimizing use of cash, doing things that move the electronic card reader away from the cashier. All of those things help to maintain physical distancing. If those aren't available, or to increase control further, use things like that we call engineering controls. So what are the ways that we change the way the premise is organized so that it can reduce exposure? So this is where those barriers, the plexiglass that's been put in place in many places, ensuring it's well ventilated and well oriented in terms of the ventilation. If you still can't, you know, there may be more you could do, or if those aren't things you can do, there are administrative controls. So things like self-screening for employees. So for any of our staff that are going into the office, they are self-screening. I get emails every morning about the people who report to me if they've had to go into the office, that they've self-screened, they're well, they're fine to go into work. Or if any of them did have, and one of two of them have over time, they're symptomatic, they're going to go for a test and they'll let us know how that goes. So that's one of the things, and we have that in place across the city, educating them on steps they can take to protect themselves at work and at home. This has been one of the challenges, particularly for people who are wearing PPE during the day all day, is to remember that they're not stepping completely away from those protections, but need to do things differently still when they're leaving work, in the break room, when they're getting home. Restricting the number of employees on site, so putting in shifts so that one group's coming in from 7 a.m. until 3 p.m., another group's coming in from noon till 7 p.m., so that they can be there at different times and minimize the overlap, or just moving things around. So our staff within Robert Thompson building have had their work location within the building and their desk configuration changed a number of times as we've had to change who's there, what work they're doing, and trying to maintain that physical distancing and all of those things in our own workplace. And then finally, that's when we turn to what does PPE, you know, for any remaining exposures that may be there, what role does PPE have? So in our long-term care facilities and for our paramedics, that absolutely means medical grade masks, gowns, all the things that they need to use in the appropriate settings. For the rest of the employees in somewhere like a fast food restaurant, it may mean about using non-medical cloth masks. So those are the recommendations again in summary. The last one, of course, is to continue to identify and address any barriers that are there. I have a few more slides that go into a little bit more detail that we managed to pick up just in the last couple of days as we put this together. Just we've been looking at things like out-of-home isolation and what that might be. And so we've talked with McMaster about what they might have in terms of having out-of-home isolation. I've gotten so used to saying hospital and isolation together. Out-of-home isolation, and you can see if the sorts of ranges of cost of what that might be. If we were to say, okay, let's offer that, and then get into, well, who would be paying for that, those sorts of things. And what we're going to do is do a survey in our community to look at acceptability and interest in this. Would people even be willing to do it? We know that cultural norms come into play absolutely in looking at these things. In some of the areas where it's been more successful, it would be more acceptable to do this, but amongst others, it may not be. So as of Thursday, May 21st, we had 605 cases. We have 649 as of yesterday. So this is just, again, looking at, what are some other supports that might be considered, cash incentives in terms of isolation or quarantine, and how much would that add up to depending on the number of cases. We had no peak. If we did have a second peak and it had, almost a doubling of cases, or if we had, 5 times the detection that we have currently. If we gave a weekly grocery supplement to people to assist them in staying home as an incentive, or we did something like free access to city services for a year as an incentive. So we've been just experimenting with, and we'll come back to you about, are these things we want to pursue further? Would they even be something that would help to increase the rate of testing and isolation? Our next steps overall are, we've been debriefing over the last little while with our public health emergency control group. The city EOC is doing the same. And we're working with our health sector partners to say, what are the things that we've learned? What are the things that's gone really well? What do we think's made the biggest difference? And what more do we need to focus on as we go forward? So we continue to do that and hear more from our partners on it. We're working more about community masking. We've had a lot now from the Premier this past weekend. And so we'll be looking at what more do we need to do? Are there some things we're looking at with the city EOC about distributing masks to vulnerable populations? Are those things we should consider? We've integrated a number of metrics that have been agreed upon now by not just the Greater Toronto Hamilton area medical officers, but also all the medical officers in the province around monitoring as we go forward to understand what's happening around transmission and developing further performance metrics. We just looked at those actually yesterday, as I said, and we'll be sharing those more with you in June. And then testing and case management. We're looking at ways to get people to testing more quickly. How could we increase that? And then be coming back to talk about how do we move forward, knowing just how much is required with case management. Isolation, we continue to work with the health sector around the best ways to isolate with the COVID cases themselves. And of course, the hospitals have been working hard with that. And there's very big challenges in having a single designated hospital when you have regional programs and specialized services in only one hospital. So that becomes very challenging. And looking at, as I said, at the voluntary isolation. And then we have a group of staff who are working with planning and economic development around safe reopening for business and helping, absolutely as the Ministry of Labor and their inspectors who are doing the lion's share of the work related to businesses reopening. But we certainly get a number of questions about the public aspects of it, or they're not understanding some component of it. And so we're supporting them as they go forward. So this is the overall piece again about reorienting. And finally, if there's any questions.
Oh, no. Yes, thank you. Thank you, Doctor. And let me just say at the outset, the work that public health frontline workers in care, but also in the background doing all the contract tracing and call centers and making these kinds of decisions and reports has been absolutely outstanding. And your work has been brilliant as well. So thank you for all that effort. This has been a challenging exercise without a specific roadmap associated with it, and we're all kind of learning as we go. And certainly the collaboration between medical officers of health, both provincially with the provincial medical officers of health, is key to ensuring that we're doing this in a coordinated way. And I'll just lastly say that the Greater Toronto Hamilton area mayors have met and have agreed that by and large we're going to try and have a coordinated effort in terms of how we open things up in the kind of broader community here, because it has varying impacts if we don't, and we're starting to isolate those areas where we need to be coordinated on. So I think that very important information that we'll share. Obviously, it's been a while since we've had council's had an opportunity to speak to this, so we have an extensive list, starting with Councillor Marula, then Collins, then Wilson, Whitehead, Clark, Ferguson, and Nunn. So I'm going to start with Councillor Marula. Questions?
Thank you, Mr. Mayor. And let me start off by saying that I think, Dr. Richardson, you've been doing an incredible job, and I commend you. And I know by extension, the community feels the same. Having said that, with respect to what we are hearing today, how reliable are the numbers from the comparison standpoint from, let's say, China and Russia or any other countries that I think questionably are providing numbers that could be, I guess, seen as political more so than actual?
That's a great question, and one that we all ask on a regular basis, I would say. We do know the WHO has been going into many of the countries over time to verify information. And, ultimately, there are some concerns about numbers and whether everybody is as transparent as they could be. By and large, most countries, though, that have now gone through this have, shown their numbers, and we're able to look at them and rely on them and gather information and science across them. So ultimately, I think, will it become a factor in terms of understanding where hotspots remain in the world? Yes, maybe that will be a piece of it. But as we're practically managing things here in Canada, and what we can do locally while we're in this phase of it, really it's our own numbers and learning from the experience of others that are the ones that are the most important for us to track.
Okay. And so it's obviously something we've captured and something that we're quite sensitive towards, I presume.
That's right.
Okay. And also with respect to the politicization of the masks and just this whole pandemic and what we're seeing south of the border and the concern of it potentially infiltrating into Canada, are we communicating strongly with other public health units throughout the province to try to really capture a message about how nonsensical politicizing a public health pandemic is? And can you just elaborate on why it's so nonsensical?
It's absolutely one of the challenges as you manage an event that's the size of this. When we're talking about communicable diseases in general, generally those are left to medical experts, public health experts, to manage those diseases. Not often do you get into the issues of tuberculosis or, group A strep or all of those sorts of things that we talk about. But when we're talking about something of this scope and the impacts that it's having in terms of the controls, it does require a broader conversation. It requires a conversation that looks at things from an economic perspective. It's not a great analogy, but it's the best one I've come up with, is our discussion about casinos and talking about absolutely the health and the public health impacts, but what are the economic impacts and how do we trade those off? And so as we're looking at the controls and something so substantial as this, absolutely having people, other experts, but also most importantly, our elected representatives be part of that discussion, part of that decision making is essential. That said, we do need to make sure we're making good decisions that are based in evidence. And so looking at what we know as we go forward, making sure we're relying on people who have the experience, the capabilities to provide that advice, whether it's, I'm not going to talk about economics because never took the course in high school, never took the course in university. I have a very elementary understanding of it, and I'm a bright individual. I mean, I get it. I certainly understand the importance of it, but I shouldn't be giving you economic advice. And, similarly, when we're talking about public health issues, Absolutely. We need to hear from people, understand what their values are, what they want to do. And there are significant decisions that go well beyond public health that need to be made. But we do need to make sure we're looking at the evidence, gathering those things, understanding what works, and make those decisions with that in mind.
And to expand upon that, I think in looking at some of the nonsensical comments that are being made, they continually look at what's occurring because it's really it's in flux. I think most people recognize that have some sort of understanding because it's a novel virus, novel meaning new, and there's no frame of reference. That some of the projections that were being made um, are actually not, I guess, seen as being accurate on paper, but in reality, a lot of the measures that we've taken has actually mitigated and improved our present situation. So our actions is why the projections aren't as bad as at the beginning we were communicating. Can you just elaborate on really the importance of understanding that we're all really in an experiment, but we're allowing the scientists to do their work to ensure that they find an answer to this problem. And can you just really, I guess what I'm trying to emphasize is there's no frame of reference. This is about science, and scientists are working on it, and there's no need for politics. How do we communicate this stronger so that we prevent what's happening? Because I'm hearing some rumblings in some corners. I'm getting really perturbed. So if we could just elaborate on that, that'd be greatly appreciated.
So you kind of held me up for a minute there about talking about being in an experiment. I just started to feel a bit like a rat in a maze there for a moment, and it's a little bit uncomfortable. But life is really an experiment. Whether we're talking about this right now or we're talking about what we're all doing from an economic perspective, a medical perspective, we're always living an experiment. The challenge right now is that this one's really in our face and quick and rapid. I would disagree with you in terms of not having a frame of reference. We do have many frames of reference. When we're talking about medicine, we often talk about going back to first principles and talking about going back to the things we know in science. We know a lot about, how things get transmitted. Maybe not this particular virus. That's what we're learning about this virus, but we know there's no magical new ways of transmission that are coming up. This is following things that we've known about for decades and decades. We know about, things that work. We know infection control practices make a difference. So it's just that the number of tools that we have that make a difference right now is very limited. We don't have vaccines. We don't have medicines. We've not done public health measures on this sort of scope and scale for many, many, many years. And so we're not used to them, but we've been using them before in the past. And so, absolutely, we don't know the specifics right now, and that's uncomfortable. That's not fun for any of us, right? And we're having to do what we have to do all the time, do the best we can with the knowledge that we have right now and make the changes that we think will work. And then we have to look and see whether or not they did and continue to learn. And that's why the work that Jason and Joanne and Adele and Doug Slider, who came back to join us when they're not back, it's his first time working in Hamilton, his hometown. But all of our epidemiologists are doing to look at what's happening globally and quickly bring that back and inform us so we can make the best decisions that we can. So there is science, there is first principles. We do need to try some things. We need to be ready to change things if they're not working, but not call it too soon. Connie Verhage, one of our city emerge planners, that was one of the things she loved to say was just wait a few more days, Elizabeth, and see if it's working because we haven't given it long enough. And so, it is all of those things that we're doing right now.
Okay, excellent. Then with respect to, I guess the frame of reference, my apologies, I was trying to emphasize that we don't have a vaccine. So my understanding, and I could correct me if I'm wrong, but when it comes to coronavirus, there is no, I guess they've never created a vaccine for coronavirus. Is that correct?
None for humans. So there are, as I understand it, and I'm no veterinarian either, there are some veterinary vaccines, but we haven't had a human virus, a human coronavirus vaccine. And so, there's absolutely a lot of researchers that are working on this, trying to create a vaccine, and including some here at McMaster University. But we don't have one yet, and we don't have a specific treatment yet. There's lots of antivirals that are used. Antivirals, tend not to be quite as easy a treatment as say antibiotics are, but everybody's working on that, trying to understand Do they work to help treat people at the beginning? Do they work when you have somebody who's got the more severe illness? Where might they be? So all that work's ongoing, but we don't have any of that yet. And we may not have any of that for 18 months, 2 years, if at all.
Which brings me to my next question. What is there is a probability that we won't have a vaccine. So the new way of living will be something that could be perpetual in our lifetime anyway. What sort of understanding do we have with respect to the impact on the actual mortality rate accordingly? So my point is on this particular front, we know that it's killing some of the most vulnerable in our community, which then now there's this debate about, because of the economy, finding a balance between the economy and people dying, understanding that a segment of the population is most at risk. So people are now really discussing the very, I guess, uncomfortable discussion is how many deaths are going to be acceptable in order to open up the economy. And from my point of view, I think if people understand that the reason why we're doing so well is because of our actions, and that if we turn our backs on all of these recommendations you're bringing forward, that we could very well be in the same situation as some of those places like Italy, Spain, and the US. And my frustration in hearing what people are saying and their complacency is that they're seeing that we're not in that situation, but what they fail to realize is because we have been so disciplined. How do we capture that in the messaging too, moving forward, rather than hearing and seeing some people believe that this thing is over right now?
Doctor?
Absolutely. And that is why through you, Mr. Mayor, that's why we are quite insistent on saying that this is not about de-escalation. This is not about, I don't even like the term recovery, because it implies that something happened and we moved past it. We're in the midst of it. We're in the middle of this all, and we don't have any of those things. And that second wave is absolutely looming out there if we chose to do things differently. The reason why we don't look like Italy, why we don't look like Spain, is because of the very good choices that almost every person has made in terms of following the advice. Has it come at a cost? Absolutely. It's come at a cost economically. It's come at a cost from a mental health perspective. And so, this is why we need, people like this council. We need people, our elected representatives, to be thinking about the balance and how are we going to manage that as we go forwards. But really, all of us rely on all of the people in our community to carry out the good work, the actions that are going to be essential as we move forward.
Okay, thank you, Doctor. And lastly, with respect to the UV light issue, I find that really intriguing. So when you're outdoors, can you explain how or elaborate on how the UV light issue mitigates the exposure to the virus?
So like many things, they don't survive in sunlight, in UV light. And so this virus is one of those. Jason, I don't know, this might be a good chance for Jason to join us for a moment. Jason, of course, is our resident who's been working on all these things. Jason, do you want to elaborate on that one a little bit more?
Sure. Yeah. Hi, everyone. Basically, the energy, the ultraviolet light is basically really high frequency light, so it has a lot of energy. And basically, when it impacts the viral particles, it's capable in a relatively short amount of time of disrupting them, so they're no longer viable and can't, go on to reproduce and infect more cells, basically.
So that then begs the question. So if I'm outdoors at the beach, and this has been really a topic of discussion that we've been hearing in the media, you're at the beach, the sun is out, but there's still a call or a need for social distancing. How do we reconcile the fact that we're being told that in the sun that the exposure is lessened, but yet you still have to practice the same measures that you would indoors?
Jason?
Right. So I guess I'll go first, but so there's not zero risk. So the virus can still remain viable for a short amount of time with exposure to UV light. So if you're right next to someone and coughed in their face, even on a beach, there is the potential for transmission to occur in that case. And there's been a very, very small number, but there have been some outbreaks linked to outdoor exposure sort of around the world, but it's a very, very, very small portion of them.
Okay, so it's still probable, but less probable.
Yeah, much less probable. It's possible, but much less probable.
Okay. And that's about it. So thanks very much.
Okay.
I really commend everybody from the Emergency Operations Center to Public Health, to the Mayor, the Prime Minister, and the Premier. At this point, as I said before, I'm very proud to be an Ontarian, a Hamiltonian, and Canadian. When you look at those numbers and you go into the World Health Organization statistics, we're 14th right now, and on that list. But when you expand upon that and you look into details with respect to the amount of testing, our population, and what's happening in other areas, we are really doing well. And I'm not sure if we're doing well because we're just lucky or we're doing well because we're doing the right things. But based on what we're hearing today, it's because we're doing the right things. So that communication needs to be put in overdrive, and I'm not sure how we do that, but it needs to occur. And I'll leave that up to the experts to pursue that
So
accordingly.
we
I
share
appreciate
that
the time.
we share that information every time we do an immediate advisory. We congratulate our community for doing the right thing. So that's a consistent message. Although we have some instances where people aren't doing the right thing, by and large, 99.9% of our population is doing exactly what we need to have them do. So that's a
I'm not sure if
consistent
it's
message.
99%. I'm not
Well,
sure if it's 99%, but
maybe
we're up
maybe
there.
98.2. I don't know what it is, but the vast majority of our population is spot on doing what we're asking them to do, and that's why we're as successful as we are.
Right.
Thank
And
you.
as long as we do that collectively with all municipalities in Ontario and countrywide, I think the message will be clearer.
Exactly.
Okay. Thank you, sir.
Councillor Collins, and then Councillors Wilson, Whitehead, Clark, Ferguson, Nunn. Councillor Collins.
Thanks, Mr. Mayor, and great presentation, Dr. Richardson. I want to speak to the second bullet point that you have in your recommendations, where it talks about increasing capacity for intensive and timely case and contact management. And I thought I heard, as part of a news release yesterday, that the province is hiring, they're ramping up the number of people who are assisting with that issue at the provincial level. And I'm curious to know what resources they're making available to supplement our own resources that we have as it relates to tracking those people who may be positive and are spreading it through the community.
Thanks very much, Councillor. Through you, Mr. Mayor. There have been a number of ways that they've been trying to increase the resources that are available to us all to assist with case and contact management. And so, there have been the drives around medical students and them being available, and that's worked in some areas. There have been Public Health Ontario has put together staff who can support it. The Government of Canada is now looking at how could they free up more resources to help support it. So we're absolutely looking at those and seeing how they fit. They're looking to develop apps, as we talked about, and an app could absolutely help with sort of initial data collection. So we're not having to do that step on it, but that personal contact is still really important. And for us, as we've looked at those options and to integrate them with our systems and make sure we're doing the pieces related to them, it's not been enough of a solution to warrant us taking that step at this point. And so we haven't gone down that road, and the resources have really gone to smaller health units who do not have the number of staff overall. And so in the long term, this is where we're going to have to look at, is it more staff we add? Is it some of those things that we take up? Is, what's going to be the ultimate solution that best suits us? So we continue to explore those, and we'll be bringing back where we're at with those as we go forward.
Okay, and thank you for that. And I was going to ask about the tracking app, and of course, there's been a lot of media and news articles, that talk about the benefits, and certainly there's the privacy issues associated with the implementation of an app as well. So is that being discussed, or is it still too premature to talk about what kind of technology we're going to utilize on a go-forward basis? As you mentioned in your answers to Councillor Marula, and you've emphasized this, we certainly don't know when or if a vaccine will be made available. And so, we're constantly trying to revise our plan to, prepare for the worst case scenario. And I'm just wondering whether it's the tracing app that you referenced there, and something that you didn't reference during your presentation, but it is referenced in the next report, and that is health screening upon entry into public buildings and areas where there may be in the future large gatherings. And I was hoping that you could touch on that issue as well.
For sure. Through you, Mr. Mayor, so the issue of of the app has been one that's been going on, and this is always the case whenever we're working on anything in public health, and it's part of the public health review going forward. How much do you do locally to try and explore these issues versus do it cooperatively across health units versus the provinces actually looking at those sorts of things? And so just like the piece about adding the race and income data, some went ahead, some of us were, then the province said they would, and then we waited for the province, hasn't happened. We're in this dance around technology, around innovation always as we go. So places like Ottawa had developed an app and are using an app that works for them, but again, it doesn't completely replace all of that work. It helps to assist with it. The province is looking at an app. They're looking at a different app than the one that Ottawa chose to use, and so we're waiting to hear more from them on that piece. We know that that there have been apps that London have used to some extent. So we're kind of in that place where we know this is something we want to do, but you run the risk of being the first person out of the gate and then somebody chooses something different. And we don't have the time or resources, and our IT group doesn't have the time or resources with all the amazing support they've been giving us and keeping us up and running to go, 2 or 3 different ways. And so we're tending to wait and see and get something that's adopted by the majority, and then we'll look at adopting that as well. On the screening front, so the screening piece is absolutely a critical piece. And so I did talk a little bit about how we do it when people are coming into work. Using screening as well. The signs have been up on city buildings that are open for some time now. Whether it's the long-term care facilities to say, don't come in if you're, long-term care facilities have been essentially closed to non-essential visitors, but for staff, for essential visitors, screen for these things. They actively then have a conversation with the individual as well to make sure they're negative. So screening certainly has a significant role to play. Whether it's going to, we see what we call passive screening if, when we go out to the stores, and some places have hired people to stand and ask those questions of individuals as they come in. So it's absolutely has a role. But when we get down to mass gatherings, what sort of level of impact would it have on a group going to a concert, for example? I'm a little skeptical about that. If I've paid, $240 for the tickets for my spouse and I to go and see that concert, and I'm feeling a little off that day, my incentives, not that anybody wouldn't want to do the right things, but your incentives sometimes get a little out of balance. And so that's where we need to see what the experience is as we go forward. And it's the mainstay of this is going to be about finding those cases, about finding the contacts, and trying to reduce control while doing the social distancing and the physical distancing and the hygiene and infection control measures for now.
Thanks for that. I know that the protocols in some parts of the world have gravitated to temperature checks as part of the health screening process before you enter either public buildings or certain areas where you may be come into contact with large groups of people. Are we discussing those issues here in Ontario or in other parts of Canada, or is that something that's still a ways off?
So the most effective way of screening is still continues to be discussed. Temperature checks are definitely part of what's considered when people are going into, say, a healthcare setting, in terms of understanding there. They're not, they're also used at immigration controls because they're fairly easy to do, but they're rather expensive to do and do well, to get the equipment to do it on any sort of mass level. So it's certainly part of it, but for now we're sticking more to the question-based screening.
Okay. Last question I have, Dr. Richardson, is related to bullet point 4, endorse universal mask wearing in the community with homemade cloth masks with at least 2 layers. Since the beginning of the pandemic, I've received probably a dozen or 2 dozen calls from constituents inquiring about where to get and purchase masks that are, I guess, that would fall into that line of those that are actually going to provide some protection. I ordered some online at the beginning of the process, and I might as well be wearing a coffee filter with an elastic band in terms of the quality of the ones that I purchased. So a lot of questions in the community. They want to do the right things. Where do they purchase them? And I know that we're oftentimes reluctant to tell people where to shop and what to buy. But is there an education campaign, and are we encouraging local retailers to ramp up and make them more available? I thought at the beginning of the pandemic, there was certainly a shortage of supplies. And so even if you wanted to go out and buy them, it was a pretty tough task in terms of trying to find a place locally. And certainly there were options online. But I still find that in my travels, through the community, whether I'm at the local drugstore or other retail outlets, they're not that easy to find. And then again, there's the whole question in terms of the quality. So are we assisting the community and living up to recommendation number 4 in terms of trying to ensure that if people want to wear a mask and want to follow the advice that you're providing, that they're actually available easily in the community?
Yeah, that absolutely. The availability of any mask, of course, has been a challenge as we go forward, and so our focus has, by and large, been up till now on medical masks and medical supplies because that's where the risk is the greatest. And so, our ECDEV, the mayor, others have been working with business to really promote retooling and getting some local production of things. When we're dealing with these, there's a variety of things. So there's some good information that's up on the Ontario website. And I think we have links up to that in ours at this point. There's some really good stuff that I talked about probably about a month ago in the CDC website about how you can make one of these masks fairly simply, and what the principles are in terms of covering nose and mouth, using some sort of loop or something to tie it behind your head, and of course, putting these on and especially taking them off and then laundering them often are critical parts to mask use. But I don't believe our economic group has had a real emphasis on supporting cloth mask suppliers. We've really been relying more on the market to respond to that need, or for people to look at ways to make them themselves. So it's a good point in terms of how we move forward. We're certainly looking at it with the EOC around vulnerable populations. Is that something that we would supply people with? But for the general population, it's a good point. They're not easy to find right now.
Okay, thanks for that information, Dr. Liz. Appreciate it.
Okay, thank you. And Councillor Wilson, you're up next.
Thank you, Mr. Mayor. Thank you very much, Dr. Richardson, for your service and all of those who are surrounding you for their tireless work. I just have a number of questions I'd like to work my way through. I've tried to write my questions down chronologically as per your presentation. So at the very beginning, when you were giving a historical overview, you talked about, and I think it's important, that these measures and means be defined publicly a little bit further. You said that since January, the city was in partial activation. And could you define what did that mean? What did that entail?
Absolutely. So just to be clear, that wasn't the city in partial activation, it was public health services in partial activation. So in managing any sort of emergency, we use a very structured approach. It's the same approach that's used across North America and all sorts of parts of the world in terms of managing any emergent situation. And it's called the Incident Management System, or IMS for short. And it is a very consistent structure about how you structure the response with an EOC director, an emergency operations director, an operations chief, a planning chief, a logistics chief, and a finance chief, a communications public information officer, a liaison who works with other agencies. And so we all use that same approach. And we do that because then no matter where you are, you know who you're talking to and who to talk to. So for example, in working between the city EOC and public health's emergency group, our operations people know who to talk to in operations. Our planning people, when they're looking at what we need to do going forward, they know to go talk to Ken Leendertz at the city level. If we've got logistics issues and need to talk about personnel, we go talk to Nancy Koka, who's the logistics chief at the city level. So it's a very structured approach. And what we do, you enact that approach at any point at which your usual day-to-day response system is overwhelmed. So we have an infectious disease program that operates every day and is looking after everything from tuberculosis to cases of food poisoning to meningococcal disease, all sorts of things. And so, when this was first going on, our epidemiologists, as they always do, are looking at, okay, what's going on globally? What do we see? And providing us with some information. Our ID team is getting ready. They're thinking about those issues, but it wasn't really impacting locally. And then as we started to see more and more information about spread and impacts and the potential for impacts here in Hamilton, we started to move into what's called the IMS structure. So to get a very systematic approach to managing at that point the information, but also starting to ready ourselves for when this virus arrived. And so that is the approach that we went into at the end of January. And then went into what we call full activation. So in partial activation, not all of our chiefs are activated. So at the beginning, we wouldn't, for example, have logistics activated because we didn't have any supplies or personnel to manage, but we definitely had planning activated, and we definitely had operations activated. And then we went to full activation. I'm forgetting exactly the date, but by February, we knew we had to have all of the units, all of the staff up and running to respond to this. So that's really what it means in terms of going through from regular business to a full emergency response.
Thank you. So, having heard that, there's been some public speculation that there may have been cases as early as November of last year. I don't know whether that's proven or not. And I guess my question, subsequent question to understanding what partial activation is, with that being activated, are you or is there the capacity to have tracing? Was it going on back then in January in terms of looking for any signs with our healthcare partners for cases?
So when we're dealing with something like this, a new virus, there is always, it emerges, and we saw the Chinese physician who unfortunately himself passed away, who talked about this pattern of new illness that they were seeing, and that he believed there was something new. And so they were able to quickly in China then isolate this virus and then isolate it based on specimens that came from there, to isolate it in labs around the world. And from there, you can start to build a test. You have to know what you're dealing with so that you can build a test to detect it. So first you start looking at the clinical symptoms and seeing whether there's something new, and what does that look like. Then you figure out what it is that's causing it, and design a test around it. So absolutely, in reflection, once that had happened and we became aware of it globally, really around the 1st of January, of what was going on in China, then people start to look back and say, okay, is this truly new? Or is this something that's always been there? So there's been that global reflection to say, no, we really do think it was new. We really do think it emerged sometime November, December in China. And we really do think this is a different virus from what we've seen elsewhere. Everybody has reflected about that. And as we've, come to understand this virus, we've had greater and greater understanding. So absolutely, we started looking here in Hamilton. All of our health providers would have been saying, if we got anything around here that looks something like what they're talking about out of China, no, no, no. But very much actively looking to see whether or not that was happening. So that really is happening in the care system, not so much in public health, but we would be there to receive any cases and to talk about them if people became aware. And so once we also then had the test, so Canada had to have a test that was validated and approved for use in Canada, then we could start to test any of those patients that came forward here in Canada. And that's where you see the first case happening, so early on in Ontario, but really we didn't have a case. There was testing going on, but we didn't have our first case identified here. There's always, though, going to be that pattern of emerging of the virus coming in, and there's always going to be that iceberg that I talked about earlier, where you have the number of people that you detect, and then the number of people that don't get detected. And, depending on the type of the disease and just how sick people get with it reliably. So for SARS, that we experienced back in the early part of 2000s, most people were really quite sick. And so we found most of those cases. For this one, you have this spectrum of illness. And so, are we finding more cases or not? And so there is always that spectrum that happens with any particular virus or disease. Jason, do you want to add anything there?
Hello, everyone. I think that you had a great summary, and I've also, read some of the speculation around whether it could have been here earlier, but I don't think that there's solid evidence to support that. And if you look at countries like Italy, where they didn't respond in the same way that we did, their healthcare system became overwhelmed. So, if the virus had been there before, we would have seen things like that happening earlier. So the fact that we didn't see that suggests that we probably were relatively on top of it.
Thank you very much. I appreciate that. On page 3, Dr. Elizabeth, of your presentation, in the graph, there are points which reference human rights plan vulnerable populations plan, an ethical plan. And I was wondering where might we find information about those plans?
Absolutely. So these are reviews that have been done by our staff. So we're fortunate to have a group of staff we were able to allocate to this to look at what are the things that need to be considered from these different perspectives. So for example, we knew early on that vulnerable populations living in congregate settings in particular were going to be a challenge, and that would experience more challenges than the rest of us might because of their capacity to isolate, those sorts of things. So we developed that with the EOC in looking at and how to support them. When it came to things like human rights or ethical frameworks, we took things that were generated by others. So from the Human Rights Commission, where they had made recommendations about things that needed to be considered, and looked at how might those apply to ourselves in public health and more broadly, and made recommendations for follow-up. And similarly with the ethical framework. So I can go back, we can look at those, Paul, and I can look at those and figure out a way to share those.
Thank you. I think that would be very helpful for me, I think, and it's certainly my responsibility as a governor to understand what policies and practices we're guiding EOC and the municipality in general when it comes to human rights and serving our vulnerable population, identifying their needs earlier and how we responded, and the ethical. What I don't see listed here, Dr. Elizabeth, and I was wondering if you could speak to it, is an equity plan. And I'd like to jump forward because near the end of your presentation, you did speak about two things that sparked my interest in relation to equity. You talked about it is easier to social distance in a big store, so a Costco type big box store, than perhaps other grocery stores. And you've also spoken about the importance of UV, but even when you're outside, you have to practice physical distancing. And of course, in some parts of our city, it is the access to that kind of space. There's a differential. And I'd like to know what role equity played in our operational decisions and guiding our responses, please.
Doctor?
Thank you. Through you, Mr. Mayor. Equity is absolutely, it's a fundamental part of public health practice in looking at equity and equitable approaches and trying to minimize health disparity that's based on, health inequities that are based on predictable factors. And so you don't see a plan because it's embedded in all of our work. Literally, it is a part of the IMS plan that we do is every day when we review them and generate them. Um, the last part of that plan is a reflection on, from an equity perspective, what do we need to think about? And so plans are, it's part of our practice day to day in terms of what we do, but it's also something we reflect upon on a regular basis. And then those vulnerable populations plans, human rights plans, ethical frameworks are points in time where we step back and consider those issues in more detail. And things that, whether it's equity around age, whether it's, and how it's impacted long-term care and retirement homes, whether it's equity from the standpoint of people who are living in shelters or people who are living on the street. We have been working with all of our programs and services and with the community more broadly to say, what does this mean in these populations? What does it mean in terms of the approaches that are needed? What does it mean in terms of the supports that are needed? So, this absolutely goes well beyond us in terms of our response to it. We have all sorts of partners who are considering in this way. I think about Tim O'Shea, for example, and his group who've been working with us and Shelter Health Network around screening of people who live in congregate settings. And so they've been doing this for almost 8 weeks now. Our public health nurses have been a part of that. So there's not a separate plan because it's in every plan in terms of how we go forward. So
I appreciate that, and that's part of my love of public health. But if I go back to Councillor Marula's salient point, that this new, I think I wrote it down, the new way of living could be perpetual. It has to be, again, my responsibility as someone who's supposed to advise or direct on policy, to apply that equity, because some of us will have different opportunities for mobility. Some of us have different access to different sizes of green space. Some of us have the ability to get into a car and drive to a big box stores where others don't. Even the movement to and I see it when I'm out, a minimal acceptance of cash. There are some residents who do not have access to a credit card or debit card. And while I appreciate that it is inherent to your practice, it may not be inherent to mine. And I'm trying to look for a way in which how we can bring through a policy measure that way of thinking to our exercise. And if there's anything you might be able to comment and how to help me in that regard, I would appreciate it.
I think, you know, what,
Doctor? Yep.
through you, Mr. Mayor, what we have done over the years in practice is about making sure that equity lens is applied into our decision making. I know council has talked about this in the past, about making sure that an equity lens is part of what is applied to our decision making as an organization. And so I think that, you know, I would turn to others who have worked on that policy and looked at how it's being applied day to day to speak more to other areas of practice beyond public health. But for us, that has been, you know, a critical part of it is making sure it is a piece of what we do each day. And I can tell you that's absolutely what we found when we're working with the OC around vulnerable populations, when we were looking at the heat-related response plan and looking at who's going to have the toughest time in terms of heat and what it means for our community and the needs that they're going to have, and making sure that that spaces were open to them, accessible to them. So I think that framework, that that lens, whichever term we use for it from a policy perspective, and ensuring it is something that we both have from a policy perspective, but then from a practice perspective, are doing that is the best way to go. It's the best way we've found so far.
Yes, and I can certainly see it. Thank you, Dr. Richardson. And near the end of your presentation, when you were focusing on risk mitigation, some of us are more able to practice risk mitigation, and whether it's our access to washrooms, hand washing facilities, our access to cash or credit, our access to a vehicle, or now a limited space on a public transit bus, and to green space. So if we all don't help, I think the case has been made that we're all in this together. Some of us just have different means in which to practice risk mitigation. It's a privilege. I would like to ask you, in full disclosure, we have had a number of conversations about the collection of data when it comes to income and race. And your remarks said you will be able to do that going forward. And is that a statement that we're not going back to collect the data? We are collecting it from here on in, or are we able to go back?
Again, we're going to have to,
Mayor.
through you, Mr. Mayor, we're going to have to decide what to do about that piece. You know, throughout all this, as you've seen, we have, you know, more than half of our staff working on this, and all of our epidemiologists and whatnot working on this on a daily basis. And so we're trying to do things once and do it really well, rather than have to do things repeated times. And that was the reason for waiting. We were, you know, set to go get started on a data collection piece when the province said that they were going to do something, and they too were debating: do we just go forward? Do we go backward? So right now we're going to go forward, and then, you know, depending on whether or not the province, you know, is able to come out with something, because if they come out with something different and we have to go back through and collect data from everybody because they've chosen something different in the tool, or they've reflected more on practice elsewhere and have, you know, good advice around that, we wouldn't want to do that twice. And so we'll wait a little bit longer again to see what the plan is from a provincial perspective, and then we're going to have to decide again what we're going to do.
Thank you. And one final question. I think I wrote it down as one of the goals less than 24 hours from case detection and isolation and contact tracing. Can you just help me understand? It was on page 18 of your slide. What is our timeline for when someone is deemed to be carrying the virus to when we do our contact tracing to those that they may have had exposure?
Doctor?
So I'm not sure. You'll let me know if I've got the question quite right. I think what you're,
I
because
think
this
you
is a
said
tricky
less
one.
than, yeah, less than, I wrote down less than 24 hours from case detection and to isolation and contact tracing. And I guess I'm asking, what is our time now? If that's our
So-
goal, what's our time now? Thank you, Mr. Mayor.
Thank you, Mr. Mayor. Through you, if you think about somebody that they get exposed to the virus and then they start to develop symptoms of having that virus, say on average 5 days later, and then they will have become infectious just 2 days before that. So say 3 days into the journey. Then they become symptomatic at day 5 and they're exposing all of their contacts. So we're going back and doing the tracing of all those that they may have exposed in their own 48 hours and then all of those afterwards. So right now, what we're seeing is, in terms of knowing the time from the time the person was likely infected or became symptomatic to the time we go forward, we're just looking at full analysis of that. But what we want to have happen is we want that time from when they develop symptoms till they go to get that test to be 24 hours,
Okay.
not longer. From the standpoint of when they get that test and it gets notified to public health, that we have as a performance indicator, and then we're working on that one from a provincial perspective too. We want the time from when that case is notified to public health till we talk to them and get to find out all that information about them, for that to be no more than 24 hours. So if we got the test result at 9 a.m. Monday, we've done all that work and talked to them about all their contacts, where they might have gotten infected, who they might have infected by Tuesday morning.
Okay.
And then for all those that are the contacts we've identified, and we're seeing anywhere from 3 to 26 contacts, all of them would have been contacted within another 24 hours. So by Wednesday morning, all of those people would have been done. So when it's 3 people, it's a little easier. When it's 26, it's a lot of work to get all of that done.
Yeah.
Thank you.
Thank
That's
you.
what we're trying to do.
Yep, I understand. Thank you. That's very helpful. So that's our goal. Thank you very much, and thank you again for your work.
Thank you. And I'm going to turn to Councillor Whitehead. Councillor.
Thank you, and thank you, Dr. Richardson, and certainly echo my colleagues' comments about the work that you and your associates have been doing on behalf of all Hamiltonians. Excellent job. I also felt really refreshed with one of your answers to the previous speaker. This is not a pandemic that is isolated to the city of Hamilton. I mean, this is a worldwide pandemic. And there's a lot of countries that have been impacted well in advance of Canada. And when we talk about some of the issues of who seems to be more susceptible to this pandemic, and certainly there was some early preliminary findings, for example, that people from minority groups appeared to be more receptive to getting COVID. The studies are underway, as I understand it, both internationally and nationally, and certainly probably even provincially. And my understanding to date, one of the common themes, which is not surprising, just like diabetes and some many other things that that affect people that find themselves for whether it's discriminatory reasons or any other reasons, find themselves in the lower end of the social economic scale, are more and likely to have more of these onsets of complications such as diabetes, overweight, obesity, will be in fact more receptive to COVID. And it's my understanding that
is this heading towards the question?
There's certainly certain communities that are being hit harder because if they fall into that category. Is that what you're understanding in your discussions with your colleagues?
Thank you.
Through you, Mr. Mayor, there's sort of two levels. I'll see if Jason wants to add to this one too. So I'll just give you a heads up there, Jason. There's the more likely to get exposed, and then there's the more likely to get really sick if you get it. And so I think we see it happening on both levels. So you think about settings where people cannot get access to, their basic needs without being in these congregate settings. Those are people who are more likely to be exposed or who can't get availability of supplies for masks if they need them, or if their family needs them. If somebody's gotten infected, they don't have the space. Like people who live in a house where they can be in their own bedroom, they have their own bathroom, their family members aren't as likely to get it. Whereas in a small cramped house where you've only got one bathroom, you're going to have more exposure of people to each other if one case comes into that family. So there's certainly factors operating on that level. We've been really fortunate, as I said, with Tim O'Shea's work, we have not seen cases in our shelter system. So that has been fantastic, but that's not been the case around the world. Then there's the piece about if you've gotten the virus, are you more likely to get sick? So we know that people who don't have access to those determinants of health on the same level as others, the people who have poor housing, just as I described, where they're living in very large numbers of people in one setting, where they don't have access to basic things that keep them really healthy, where they may have higher incidence of chronic diseases as a result, then they're more likely to get really sick if they get the virus. They're more likely to have the respiratory complications, to end up in a hospital, to end up in an ICU on a ventilator. So it kind of happens at both of those levels.
I appreciate
Jason?
that. I appreciate that clarity. And I think what's more important to me is that we don't have the resources that some of these international bodies who CDC and so forth, and we have our own equivalents here in Canada. So I was glad that you identified not only don't you don't have the resources, but I mean to suggest that we're going to duplicate so many other studies that are going to be going on here in Canada would be just a waste of taxpayers' money. So I really appreciate that answer. I wanted to focus on the mask for a second because the CDC did say that the masks aren't effective originally. Then they qualified that statement with saying, well, we were worried about the shortage, and findings are that it can be helpful, but my understanding the jury is still out on that front, and I'm going to get to that in a second. Your eyes are still exposed. My understanding, one of the entry points for COVID, those particles you talked about, is the eyes, your hands rubbing your eyes. So if you're not wearing a face shield, you're just wearing a mask, how helpful can that be? What level of risk are you still exposed to?
So this is why we talk about how the backbone of this are some very basic principles. They are, physical distancing is really key. That keeps you out of, you think about that hierarchy of controls again, that keeps you away from needing to worry about any of those other pieces. We've tried to go to the stores when they're not as busy. We talk about all of those sorts of things as part of it. And we talk about why covering your mouth when you sneeze in some way, shape, or form. We talk about washing your hands often. We talk about keeping your hands away from your face, entirely. Those stay the backbone no matter what. And part of the controversy around the masks has been both, are the cloth ones as effective as the ones we can now make synthetically? But it's also about the fact that we need to be so careful when we use them, because if I have a mask on, I'm wearing, while I'm out and about, and then I go like this to take it off, well, I've just got whatever's all over the mask on my hand, and so no, it's take it off by the ear loops or undo the pieces and then put it straight into a bag that's going to go into the wash, very shortly thereafter. And so absolutely, it needs to be done really well. We call that donning and doffing the mask. Those need to happen. Part of the concern early on around mask use was that people do tend to then touch their face off, and it doesn't fit quite right, it doesn't do this, and so some of the cheaper synthetic masks are quite like that you might get if you're out and about that a store provides. They don't fit well over the nose, they don't fit terribly well, and so there you are, you're up around touching your eyes, you're touching those things, so they don't make a difference. So there's no doubt we're still looking at how big a difference will the masks make. That's absolutely there. In terms of eye shields, yep, they add another layer of protection. Some places are just using the face shield in order to prevent any spread in that way. So, absolutely, some eye protection does add some protection, but it's what we're trying to do. That's really protecting the recipient. In terms of the spread, the masks are really there to stop that pre-symptomatic and asymptomatic spread. So that's the piece that's most critical. Eye protection is not going to change that. Eye protection can change it on the receiving front. And Jason, anything you want to add on that piece?
That was great. Yeah, just really the main, I think, point there is that it's really wearing a mask. It does provide some protection to yourself, but it's also an act of altruism to protect others. You don't know that you're infected. Many people are pre-symptomatic or asymptomatic, and so that's really a big component of it. And if we kind of chip in as a community and a large proportion of us are wearing it, then it won't matter whether you're wearing eye protection as much. Yeah.
Thanks, Jason. Councillor?
Thank you. Well, I also understand that cardiologists have come out now and indicated that not everyone they would be advising to wear a mask and wearing masks long. People with asthma, which I have, I did try a mask. I can tell you, I felt like it was suffocating. So I'm not clear exactly because what's happening is there's this new norm, but this new norm isn't appreciative of the fact that it's not equal to all in the context of putting a mask on. Some people have claustrophobia. Throw a mask on and they go into a panic or anxiety. So I'm trying to understand. So we're dealing with norms that there's a lot of ignorance out there that, I just saw a clip of a woman in a store being attacked by people wearing masks because she wasn't wearing one. But there's some ignorance in regards to not all people can wear masks. So how do we educate?
Yeah, I'm so glad you raised that, Councillor Whitehead, through you, Mr. Mayor. The issue of this is why masks aren't required. They're highly recommended because not everybody can or should be wearing a mask. So for kids under a certain age, they should not be wearing a mask. There are people with medical conditions who can't tolerate a mask. And we talk about too, when we're doing transfers, even from long-term care homes into hospitals, that ideally they wear a mask, but if they're not able to, then they can't wear those. And absolutely, I can empathize with you around the asthma piece, because when I was sick during the course of this, I had developed laryngitis. My asthma acted up, and I had to wear a mask to go in and get seen. And it wasn't a fun couple hours while I was doing that, but it's absolutely essential. And as long as I could tolerate it, I did that. And so we do need to, this goes back to Councillor Wilson's point about equity, and we do need to all continue to do the excellent work that people have done to control this virus, but we also need to make sure we're not bringing judgment into the picture. And so whether it's judgment around mask wearing and understanding what people are doing, or it's judgment in other ways, we need to understand each of us is trying to do our best, and we should. I think the mayor said earlier something like 99% of people are trying to do the best. We hopefully it's somewhere up there in that number. There, of course, will always be people who have a different idea, who don't want to follow along, and we'd really like to convince them otherwise. But there will also too be some people that just can't follow all of these measures for very good reason. And we need to have empathy for them. They don't want to be out there. They don't want to be spreading it, but they have something that's limiting them from being able to do that.
I'm so glad you said that, because it is concerning to me. There's enough anger and tribalism in our society that my concern is that we're going off on a front that here's a risk mitigation practices, and then we just provided yet another tool to disassociate or be very critical of people through ignorance and non-understanding. So I just want to make sure that we're getting that education out there that, if you can, you should wear a mask, but not everyone can. And we need to understand that as well. The last question is mortality. And we're going to get these studies. They're happening and they're ongoing internationally and nationally. But there are some preliminary findings. I think JP Hopkins did some research, and they're looking at Sweden and other models, and they're actually coming up that the numbers aren't that far off between people that kept their economy running and others that completely shut it down. So and the mortality rate, although in some countries is up as high as 1, goes down as low as 0.04%. So it's getting into that flu range, and yet our response is so much different than so many other, SARS and H1N1. So What's your response to that?
Yeah, absolutely. This brings us back to the piece about that iceberg analogy that I used, and so there's the case fatality rate. So the people who we identified as cases, those people who were sick, got notified to us, and we know about how many of them died. And then there's the infection fatality rate, if you will, all the people that got infected, how many of them died. And so depending on how well a country is doing and getting testing done, and understanding what their number of both cases, people are symptomatic, and their number of infections are, that number, that proportion will vary. So as you saw from the work that Jason pulled together, when you look at places that are intensively doing case and contact tracing, that are intensively doing testing of symptomatic people, trying to get those really short turnaround times to people getting tested, and then really helping people to isolate to minimize spread, then you're going to have been finding a whole lot of them preventing more, and your fatality rate will look lower because you know about more of the cases. Here in Hamilton, our case fatality rate sits at about 5%, and it's been sitting there for some time. But again, we probably only know about somewhere around 10% of people who are actually infected overall. And so what we do see, which is really encouraging, is that piece about community spread. We don't see a lot of that in Hamilton compared to elsewhere in Ontario. So that helps us know we're seeing more of that iceberg, but we still want to work on that, understand it as we go forward, and depending on what we do, how can we continue to do all the things we need to do. There's principles of something called necessary and sufficient that we use in epidemiology in terms of both causes of things and how we treat things. So we want to do everything that's necessary to control this virus. There may be a subset of things that are sufficient amongst those, that if you do those three, they're the most important ones. And that's what we're learning together globally in terms of what they are, and continually improving what we do. And we've been very thankful for Jason and for our resident colleagues, because they've been key in gathering all of that international data for us and helping us refine our approach.
So, Mr. Mayor, I did, for clarification, in that same question, I didn't get an answer, so just give a chance. But the findings, preliminary findings from preliminary research, and still research out there, the numbers aren't that far off between full economies, or economies that basically pretty well stayed open, versus ones that went complete lockdown. So the arguments you make is based on how the response of the country is in regards to the numbers of mortality, yet there's other findings saying numbers aren't that far off overall.
So I think that's what I was trying to answer in the first part about, it depends on how many of the cases we understand about in terms of what is going on and the extent of the control measures. And absolutely, we need to figure out which ones are doing what. But we didn't have the extent of testing. We didn't have, because it had been used up by other countries around the world who had this virus first. We didn't have the ability to do the contact tracing to the extent that we had elsewhere. And so as we refine and go forward, to understand where that balance point is going to be really important. As long as we're talking about case fatality rate, remember though, that's different than talking about mortality in the general population. And so when we're focused on cases, we would expect that number to stay similar.
Thank you.
Thank you.
Okay. So I'm just based on where we are, we have three more speakers with questions. I've allotted about 15 minutes for each major significant community issue. So I think everyone's kind of kept in that timeline, and I'll keep you at that timeline for others. And we will take a break once we're done with this issue, and then come back to the re-engaging employment that Paul Johnson's going to present to us. Councillor Clark, you're up next.
Thank you, Mr. Mayor. So I'm trying to understand how we define the mortality rate then, because when I'm reading the Johns Hopkins University, they've been giving these monthly reports on mapping and trending. They're showing mortality rates as high as 16% in Belgium. They're showing Canada with a mortality rate of 7.7%. So how do they define, doctor, the mortality rate?
So this has been one of the challenges, right? Is it's all using similar statistics and measuring things similar ways. So for example, you often see us just talk about the absolute number of cases in Hamilton, 649. I can tell you when you work that out as a rate per 100,000 population, where we sit compared to others in Ontario West, which is everywhere from sort of the Dufferin border all the way out to Windsor, that we sit pretty much middle of the pack, that we're not the lowest, that some parts of the province have lower rates of COVID-19. Other places have almost double the rate that we have. So there's a fair spectrum out there in terms of the rate of COVID infections in the whole population, and we sit about middle of the pack. Same thing when you're looking at mortality rates. And as I was saying earlier, when we're looking at case fatality rates, it's going to be amongst those cases, how many people die. So it depends how many of those cases do you find? What's the spectrum of illness? How sick do people get? So if you're only finding the very sickest, well, more of them are going to die. If you're finding people who have that whole range of illness, which we now know can be anything from a very mild illness to something very severe, well, your mortality rate's going to come down because you're finding more of those people. Then if you turn and look at that as the entire population, so how many in the entire population die, you're gonna have something that's a bit more comparable. I'm just going to turn to Jason to see if he has anything he wants to add on that front.
Thanks, Dr. Richardson. I think this is an area with a lot of different confusing terms, and there's a difference between mortality rate and case fatality rate, even though they sound like they're talking about the same thing. So a case fatality rate is when countries are reporting that, and Johns Hopkins is reporting that, it's among the number of cases that have been confirmed by lab tests, how many of those individuals died. Whereas when we're talking about mortality rates, we're generally looking at the number of deaths in the population relative to the overall population level. And so that's an important difference because the case fatality rate that we're observing in Canada is, and here in Hamilton, is dependent on the degree of testing. So the more testing you're doing, the lower it will look, even though there's no difference in the actual rate of death necessarily. So in South Korea, for example, they're doing a ton of testing. They see a case fatality rate of 0.4% or maybe higher, like 0.7%. But the mortality rate, which looks at how many deaths there are in the whole population, that is more of an indicator of what the impact of the virus actually is and how effective the physical distancing measures are. Unfortunately, in Canada, we don't get overall mortality data fast enough to be able to report on that at this point. But in some countries where they do have that, for example, Spain and Italy, it does have a relationship with the, how quickly they instituted measures. So in Spain, for example, they saw during their peak almost twice the number of deaths out of the whole population compared to previous years. So that showed that they didn't have a good level of control at that time. Well, we don't have that data yet for Canada and Hamilton. Because we responded well, it would likely be much lower than that. I don't know if that explains it.
Ms. Clark?
No, it helps a great deal. So there are variances that, depending on how they actually put the stats together, that can change the numbers. Can I ask a question then with regards to the testing protocols and in mind of the last answer? The province of Ontario, as I understood it, were the ones that set the testing protocol. And initially they indicated that there was a subset of symptomatic residents or residents who were reporting symptoms to their doctor or to public health that were being tested, but not all symptomatic residents. So I had a plethora of phone calls from residents who went to the doctor, they had all the symptoms, and yet they were sent home and told to self-isolate. Given that anecdotal information, is it possible that our actual numbers of infections here in the city were higher or in the province were higher, but we weren't testing them all at that point like we are today?
Yeah, it's through you, Mr. Mayor. This testing piece has been a challenge. And so as I was trying to describe, over time, we initially focused our testing resources as a province on people who had key risk factors, and they were travel. They had to have the first set of symptoms that we understood, and then they had to travel or be a contact. So anybody else who presented with those symptoms, we weren't testing in the initial days. And then as we went forward and started to understand a little bit further, and we knew that travel was no longer the main issue around spread, we started to move into spread between contacts and cases, or between and start to move into community spread. We then ran into challenges with the amount of testing resources we had. So they came up with a prioritized list of who to test, and we had to stick to pretty much the top of that list for some period of time. And so there's absolutely no doubt. I mean, it would happen in any case. that there were people who thought they just had a usual cold. It sounded very much like something that their child had had, and they thought it was just a childhood viral type illness. It might have been somebody like myself who's an allergy sufferer who thought their allergies were starting up a little bit early, that it really wasn't anything more than that, or they had diarrhea or gastrointestinal symptoms, which you now know can be associated with COVID. And so it never even crossed their mind they might have something related to COVID. And that's why we've heard talk along the way that anywhere from 10 to 100 times as many people have been infected as the number of cases that are officially reported. So there's absolutely no doubt that that's the case, and it is the case with any sort of virus. We always only see a portion of people who are actually infected. That said, that's where the seroprevalence, as we call them, surveys, these studies where we go out and test people's blood to see how many people were actually infected along the way. And so the test to do that was just approved, I think it was last week for Canada. It's been out there already in other parts of the world. They had developed theirs, and Health Canada has just approved the one for use here in Canada. And they are beginning those surveys to look at blood that's collected usually for other purposes to see how many people have actually contracted the virus.
Ms. Clark.
Those sero test surveys, when are they actually starting, Doctor?
My understanding is, reading up some things last night, is that they have begun them. I'm not sure here in Ontario exactly. I mean, this has been part of the plan going forward around both a testing and a surveillance strategy. I don't know, Jason, have you seen anything more recent on those?
What I'm aware of is that one of our largest studies in Canada, the Canadian Longitudinal Study on Aging, is that they've either done or are very close to beginning one of these seroprevalence studies. And there's a number of others working on this as well. Sorry, no
Okay. Thank you very much for that. Doctor, if I may, when I look at all of the recommendations that are in your report, and they are all prudent, and I fully support exactly what you're proposing, I'm equally trying to understand where we are with the province in terms of the funding for public health. So when I look at these, and we're talking about increasing the capacity for intensive and timely case contact management, as you know, is not inexpensive. Tracing contacts is not inexpensive. It's a heavy person power type system. So do we have any numbers on the costs that we have incurred, are going to be incurring, and whether or not the province has agreed to funding public health to assist us with these additional costs?
So you'll be glad to know through you, Mr. Mayor, that costs, of course, always remain on our mind. Cost consciousness being one of the key things that all of us in the city think about, and we think about in this response. And Dave Cervizani, our finance manager, has very much been, as our finance chief, has been at the table devising ways that we track our expenses, that we track the costs that are related to the response. And as you can see through the reallocation of staff, while we have hired some additional staff to help us. We've brought back a number of our retirees who have just been fabulous in coming back and helping us on this front. They bring expertise to the table that really helps. We have also been trying to track just how we're doing relative to our usual budget. So we've done some preliminary work on that. We have tracked all of our expenses as we go forward to make sure we have them there in case the province, the province has told us that they have about 100 million, I think was the dollars that they announced, that would be available to public health for the COVID response. That 100 million, I believe, would include the laboratory expenses, which we know are extensive in responding to this. They haven't given us specific guidance around what to expect from the standpoint of supporting public health units and what the expectations are for public health units to when we go to reopening our programs and services. Our central services have been maintained throughout, but there are a number of services. We need to get back to, medium and low risk food premise inspections. We started back on our high risk ones a couple of weeks ago. We'd always been doing complaints or any issues of that nature, but there's a number of lines of business that are really important in terms of looking at the health and wellness of our community that aren't COVID related that need to get back up and running. And so, we've asked for further guidance around that. Absolutely, the role of this council in terms of being our Board of Health and your direction around, how you want us to manage those things are key. We, as I said, we've done a preliminary look. We are tracking those expenses. We're in the midst of doing a more fulsome budget variance review. It won't be nearly as detailed. I mean, our staff, our management in particular, are focused on responding here and maintaining our services, but we're doing our best to continue to track that. And so we'll have more data for you on that as we come forward to the June Board of Health and into the July Board of Health and ask for your direction about where you'd like us to go on that front.
Thank you. I guess I'm just nervous at the 100 million that they've talked about when we're looking at all of the public health agencies across the province. Heck, Toronto alone would take up the majority of that 100 million with the costs that they've incurred. And so I'm hoping that the province is looking at it quite seriously and making sure that municipalities are made whole. They did their job, but they can't put this on the backs of the property taxpayers. I have a specific question with regards to long-term care home visits. I know that the visits have not been permitted and that long-term care homes have encouraged people to visit through windows on main floors, et cetera, et cetera. Now what I'm getting reports of, at least in my ward, and as you know, I have a couple of long-term care homes in my ward, is that the visitors are going to the windows and the windows are being opened and people are speaking through the screens. Is there a concern from a public health aspect with regards to the safety of the patients inside or the residents inside?
Yeah, absolutely. The exclusion, this is such a tough thing for long-term care and for all of their families. Through you, Mr. Mayor, the need to be distant from your loved ones when you're going through something that is a significant health issue and carry such risk for people who are in these long-term care homes. And so our hearts absolutely go out to these individuals and their families and what it must mean to go through these times. Essential visitors have been allowed to continue, particularly in cases where somebody is nearing end of life, but also in critical, for critical care aspects in those areas. Those have been allowed as well. The window visits, particularly during the winter months, were thought to be a really good way to maintain distancing. You got a physical barrier between the two people, you're golden, right? This is that first level, that second level of engineering controls is a physical barrier being interposed between two people and things are good. But if you open that window back up, then you're back to needing the bigger distance between people. And so I know we had a complaint related to one of these that came through yesterday that our inspectors are going to talk with the home. They may not be aware that it's happening, that somebody's opened the window, whatever it is, but they'll work it through. And so if there are those sorts of things happening, absolutely, it's good to raise it directly with the management of the home to make sure they're aware of it. And if you call through to us, we'll follow up as well.
Okay, I'll fire off an email after the meeting today. The last question I have, Mr. Mayor, and I thank you for your time. The second wave and the potential for shutting down the economy has me and I'm sure many of my colleagues and business leaders in the community a little bit nervous. So given the recent push for the wearing of masks when in public, and we know they're not perfect, and the social distancing, and the abilities to quarantine infected families, and understanding that there could still be people out there who are non-asymptomatic, I guess is the terminology, and could still be shedding the virus. When we're looking at the next wave, what are the chances of keeping the economy open as opposed to shutting down the entire economy? But putting certain things in place and protecting people the best we can to keep the economy moving so that people are working.
Through you, Mr. Mayor, that is the $64 million question.
I thought I'd ask
as we
it.
go through.
That's $1 million question, actually. A multi-billion-dollar question.
A multi-billion-dollar question as we move forward, and really, this is in our hands. That's the good news. It's tough because we don't have individual control over what happens, except in a very small sphere, but we do have collective control over what happens with this virus. And we have done as a community, as a country, a tremendous job in responding to this virus, at meeting the measures that have needed to be put in place in order to shut this down. And as you see from Jason's work, you can see that other countries have managed to do it and not shut down their economy to as great an extent. And so this will be the question about, you know, we need people not to get fed up, not to get frustrated. We need them to continue to understand that the physical distancing, all of the things, the hand washing, those sorts of things are key. That we need the economy to get back up and running. We need people to have jobs. We need people to work. We need people to see one another. We need all of those things. Those are all critical to us from a health and wellness standpoint. So we all need to do the work to limit that spread. We need to support people who are ill, to isolate so that spread is reduced. We need to not bring judgment to the table, as we talked about earlier, but to understand and empathize. We need to protect those who are at greatest risk, so that we can make these changes. And we need to make the investments in the case and contact management, so that we can identify them, follow them up, and hopefully go the way of Taiwan and Hong Kong, and continue on down that path.
Thank you. And so, Mr. Mayor, as we move forward now, the Emergency Operations Center is still operating, but we're getting our standing committees up and running. So I'm assuming public health will be up and running. And as we move forward, we can continue to ask questions of this nature in a public forum. I know we've all been doing it by email, but in a public forum, which will help to educate the broader public. Is that the intention?
Yes.
Thank you, sir. I appreciate your time.
Alrighty. And I'm intrigued by Jason's background here. It looks like our epidemiologist is working in a white sterile room here, because there's nothing but white. Interesting background. Councillor Ferguson and then Councillor Nett. Councillor Ferguson.
Yeah, thank you, Mr. Mayor. And Elizabeth, as everybody else has said, we're sure getting value for public health these days, and the public sees that. We appreciate the work that your whole department is doing and the Emergency Operations Center, so thank you. I've only got 2 questions left. I've already learned a lot in your presentation and by questions others have asked. But on your presentation on page 7, it puzzled me why you said the most vulnerable, disproportionately impacted were complications of diabetes and hypertension. And both those are chronic diseases that are treated through medication. Is that because you're finding there's a shortage of medication for these 2 types of diseases?
For you, Mr. Mayor, so the most vulnerable, disproportionately impacted is meant to address all of those things that are in that slide. The fact that our jobs that are lost, tend to be jobs where, people are working in fast food, or they're working in settings that have been closed down. When the increase in unemployment, makes people, particularly affects those who have, less stable jobs, that sort of thing, the gig economy. Suicide risk tends to affect those who are already vulnerable from a mental health place, people who are already struggling. Substance use similarly. So it wasn't meant to just apply to complications of diabetes and hypertension. So my apologies if that wasn't clear. But absolutely, for those who have diabetes and hypertension, again, those tend to be diseases where people may not have as much access to care, to the things they need, the food, all of the counseling supports that they need in order to manage those diseases. So they're more affected as well, but it wasn't meant to be specific to those.
Okay, because I certainly understand the other 4, but when you zeroed in on those 2, they're heavily controlled by medication, and the pharmacies are open, and I'm not hearing about any medication sources for the medications for those 2 types of diseases. There are lots of other chronic diseases out there, cardiac problems is another one that's a chronic disease and ongoing treatment needed. So it really struck me that you picked those 2 and as an examples, and as someone who has both those things, I don't feel challenged at all by it, because I can still manage them both very well. And I hope the public isn't getting the perception that those 2 diseases, chronic diseases, are very much more vulnerable than others. So I'm hearing that's not.
don't think that was the point. I think the underlying health issues for anyone is potentially compromising when it comes to COVID. Doctor?
That's right.
Okay.
Okay. And my last one is on page 19, where during Hamilton's peak, we were at 12 cases daily, and currently we're at 4. And I think you mentioned this information is about 2 weeks old. Would the 4 have gone down the last 2 weeks? I know you don't have the data in front of you. What's your feel?
So it's gone up and down. The Roslyn outbreak, of course, drove that number way up in terms of our having a spike again, and then all the follow up that happened. Then we've been sitting, and we're starting to monitor this. We've been sitting somewhere around, we'd been down to 10, and then down to 5, and so we're sitting more closer to that number, I would say, at this point when we look at when the onset of cases were. So we're sitting around about that right now.
Around 4. And I think
5.
5. Okay, so it has
It's
gone
somewhere
up
in there.
slightly since this report was prepared.
Yeah, I would say somewhere in around there. We're just redoing that analysis a little bit to check it. So I would say somewhere in that range.
Because I think that those type of numbers, which is looking at the long term, are very helpful. There's a lot of people frightened out there. And I think the mayor said that about 95% of the people are following the recommendations of public health around social distancing and staying home. And so when they see this type of progress, I think that would make them feel more comfortable. And so I hope the media is picking up on these stats, because if you watch CH every night, it seems to jump all over the place. But when you see it averaged out like this, it definitely shows that we're doing better. And so thank you for that information. And I'll be using these statistics regularly when I'm replying to my constituents now.
Thank you.
Oh, no, that's all for now. Thank you.
Okay. I think that should not allow people to relax, though. And I think that's part of the message based on all the good work we've done to date, is that, yeah, people don't need to be, panicked about this, but they also need to maintain that physical distancing and some of the measures that the doctor talks about. So
yeah, I think the people that are not adhering to it, like the group in the park on Saturday, are anomalies. I agree with you, Fred, that the majority of the population are doing a good job at this. And I also agree most are frightened. And if something I'd like public health to think about is, I've talked to some people who are still closed and in their stage 3, provincial stage 3, before they open. They're prepared to sit back and do their part and wait till stage 3 opens them up, but they're petrified that we've scared the daylights out of people and they'll never come back. And you may think about how we can message that to the people who are behaving themselves and maybe going too severe on themselves, making their life and difficult. And there's going to be lots of conditions on restaurants, and they know it. You're going to have minimum 2-meter separation, which is probably running at 50% of capacity. Councillor Farr's motion went a long way to help that by opening up some patios. But if you can think about some messaging that can happen when phase 3 comes, to make people comfortable that they can then, providing they follow by the rules of the day, and start to go out and patronize these businesses and enjoy themselves. So
yeah, I think we all agree with that. I think.
Okay.
Thank you. Appreciate that. Councillor Nan, and then Councillor Danko, and then I'm not going to troll for additional comments after that, because it's an appropriate time to take a break. So, Councillor Nan.
Thank you. Through the mayor, thank you, Dr. Richardson, for your presentation, for all your work over the last 2.5 months, and definitely joining the chorus and extending our thanks and gratitude to everybody in public health for all the work that you have done to help manage us through the first wave of this pandemic. On the timeline summary that you started off with in the presentation, it really kind of gave a good sense of how sober the perspective is in terms of how much heavy lifting has happened over the last 2.5 months and how quickly everything has shifted in our community and around the world. I thank you for putting that timeline up front, because I think it's important for us to keep things in context. I did have a couple of questions on the slides. I think my number of questions have reduced thanks to our colleagues around the table. But one was around the trajectory, the actual trajectory graph that we saw today for the first time that charts where Hamilton is at. And it, to me, it appeared as though it's kind of midway between high and middle, but you had referenced it, or when you spoke to it, you spoke to it as a trending in a manageable way. And I know that it's difficult for you to make any kind of forecast, and it's not what I'm asking you to do, but just to give a little bit more clarity around where that actual line is versus the high number and the middle arc.
So absolutely, and we'll see what Jason, because he's done all this good work, can add to it. What we've been trying to do is forecast using mathematical models, and reality is always way better than than models in terms of once you understand them, but you can't know them in advance. And so the low level of projected cases was based on sort of best case scenario. And you can see it leveled out earlier and, had the total number of cases lower. And the high one is based on Italy and places that have had more severe, and it kept climbing and, didn't level out for some time. So it had a longer, rising peak versus the low one. And then the middle sort of area is, what has happened with the other places that have similar kinds of control measures in place. And we're tracking along about that middle ground. And so we certainly had a rapid rise in cases for many weeks there, and then it started to see them plateau and level off, and are having fewer numbers every day. As we said, we peaked out at about 12 on average. We certainly had days that were much higher than that, particularly around outbreaks, but we've leveled that piece off. And Jason, do you want to add anything? You're the modeling expert here around our table.
Sure, I'll add something just quickly. So those projections were calculated on April 6th, which was a couple days before we changed our testing criteria on April 8th. And this goes back to that whole iceberg analogy, where at any given point in time, we're only detecting.
I'm not sure where you're holding your microphone there, Jason, but it's you're kind of fading away when you're speaking. So,
oh, sorry.
No worries. Yep.
How's this?
A little closer would be better. Yep. Thank you.
Okay. So it goes back to that iceberg analogy where we're only detecting a proportion of the true cases that are out there, probably, somewhere around 10%. And so when we changed our testing criteria on April 8th, we might have been only detecting, like, we don't actually know the true numbers, but a smaller percentage, and then we increased up to 10%. So some of the increasing cases that you're seeing there isn't actually related to increased transmission of COVID-19. It's more related to us just picking up a higher percentage of the cases that were already there. So if you were to remove the cases that were related to the increased testing, we actually probably would have fallen even below the middle line. We did quite well actually in Hamilton here in terms of all the measures that we took.
Okay, thank you for that. Through you, Mr. Mayor, in terms of the data that's to come based on 2 weeks old versus what we'll see coming up, there are some rumors in the community about Mother's Day kind of peaking the numbers in Ontario. At what point will we get assessment of whether or not Mother's Day had an impact here in Hamilton?
So it's interesting because our colleagues at Public Health Ontario are trying to give us, their primary look is at the provincial basis, but they're trying to get us more, local calculations that will help us that we're not able to do ourselves, because they have access to all the rest of the data to make comparisons and whatnot. And so they had given us a graph of what's called R effective. So it's the number of additional cases that we're seeing that are happening out there. And our peaks have by and large been related to specific events in retirement homes and that sort of thing. But yes, absolutely, the question of, how many days post what did these relate to? And so we'll go back and take a look at those. As our numbers are getting smaller, it gets harder to find. We're not having, peaks of those big events kind of overwhelm everything else, and it's harder to see little peaks that may happen. But that's where our hot spots have been, by and large, has been around institutions who've had a challenging time doing the infection control that's needed. And the other thing is just within families themselves. A number of a lot of our spread, as you saw, is related to spread within families. And so that's where the testing of people who are asymptomatic contacts is really important for us to identify who else might be infected, and is considering, should we offer somewhere where people who are infected could go to try and limit that spread.
Thank you. I appreciate that. On the slide that was looking at the stats regarding those who've been made most vulnerable being disproportionately impacted, I was curious about, you had mentioned the impacts that were listed there, but that there might be several others. The sense of whether or not the adverse kind of impacts from COVID and our physical distancing measures and what kind of statistical data we have that helps us understand intimate violence or sexual violence rates in the city. And I know it's a difficult one to track from a public health lens because it requires individuals to be able to see a physician or see a medical professional in order to report that. But is that, I guess, is that data being compromised in terms of collection because folks are hesitant to go or reach out to talk to their medical, the medical community about what they're facing in their homes?
Thank you. Through you, Mr. Mayor. What we're doing, the EOC, along with ourselves, are looking at data that comes through police, EMS, as well as information that comes through the healthcare system in order to track some of these issues in the vulnerable population. So things like spousal abuse, those sorts of things, violence in the home are definitely being tracked from a police perspective as well as from a health system perspective. And so you're right in that we have seen this phenomenon that people are not as willing to go and get looked after to report things. You know, this is on a health perspective because they don't want to go to Emerge because they're worried they'll get COVID when they go to Emerge. And again, they may be worried about getting COVID if they go then. If that's been their experience. So we're trying to use not just the health data, but other data to look at that. And we know that some communities have seen increases in those numbers, and we're going to continue to track that as we go forward. Our main one right now has been around mental health ER visits, and it's quite clear that there's mental health impacts. We would expect that because of all the things that are going on. And our mental health staff internally, as well as our partners around the community, are looking at ways to get more services out there to support people, and again, to encourage people to engage with them. And the reality is that most of mental health work is based around relationships, and relationships in this way over a video link, it's good. We've been doing that. Lots of people have adapted their practice so that they're doing it this way. But face to face does tend to be something that's more effective. So they're looking at ways that they can open back up.
Thank you.
Thank you. Just a couple more questions in this realm. So you had mentioned, Doctor, the race and income data starting to be collected as of yesterday. Is there any other demographic information or other demographic categories that make up the fulsome spectrum of the data that's being collected?
So some of that, through you, Mr. Mayor, there's some of that data is routine data that we would collect in any case, things like location, that kind of thing. I'd have to go back and look at the actual tools. I don't know, Jason, if you've looked at them more closely in terms of the specific pieces, but we could share with you the tool that's being used, the additional questions we've added.
Additionally, I mean, there's things like age and sex that are being captured, obviously, but and some occupational data related to healthcare workers as well. But beyond that, I'm not aware of the additional pieces.
Okay, thank you. The reason I was asking through you, Mr. Mayor, is that in terms of that understanding of impact, there's the importance of making sure we're clear about who's being impacted and how, but there's also the piece around how it correlates back to the economy in terms of if a quarter of our population who've been tested positive for COVID-19 are frontline workers, then it's helpful to understand who are those frontline workers, which of those positions are the ones that had ticked up the cases, and what were the conditions of their workplace that facilitated that or led to that. if it's predominantly in the retail sector, if it's predominantly in the healthcare sector, if it's predominantly personal support workers, we know that predominantly it's women workers, it's racialized workers, it's immigrant workers who are in those positions. And so that's where that data and demographic information becomes so critical, not only in terms of understanding the impact of COVID-19 on our population here in Hamilton, but thinking about it in terms of future planning. So how are we using that information to inform our economic recovery, our work with our business communities? How are we using that information in terms of preparing for hopefully not a second wave, but the potential of another health crisis coming down along the way in the future?
Doctor?
So the rest of my questions were covered by others, and I appreciate the time. Thank you.
Okay, thank you. Councillor Danko, and then we'll receive this and approve the information report. Councillor Danko.
Thank you, Mr. Mayor. And I just have, I think, one kind of quick question for Dr. Richardson. On slide 16, it's the slide that had the multiple bell curves with intensive case and contact management and the percentage of cases infections that were pre-symptomatic, symptomatic, environmental, and asymptomatic. So through the presentation, Dr. Richardson, there's a focus on testing symptomatic people as quickly as possible to determine if in fact they are infected. But I'm wondering about the pre-symptomatic and asymptomatic cases if we're thinking about community-wide random testing as some other municipalities have gone to.
Thank you. Through you, Mr. Mayor. So the whole piece about testing, and we've seen a much greater number of tests able to be done in Ontario. We're moving towards 100,000 tests a day. There's sort of two lines of testing that need to happen. One is the surveillance, understanding what the patterns are of disease in our community, and then there's the ones that are about disease control. And so this really speaks more to the piece around disease control and where can we find most of those cases. So if we're focusing on those who develop any of the symptoms that are related to COVID, encouraging them to get tested ASAP so that they can isolate and reduce the chance of spread. And then talking to the people that they were with before they became symptomatic, where they may have gotten their case from, and those who they're in contact with now to test and isolate those individuals. That's going to cover, as you can see, the lion's share of people who are spreading the virus. And so while we, definitely look at the other piece around understanding where the virus is in the community, really we're only going to pick up a very few cases that are spread in that way. And so that's sort of why the emphasis from a public health control perspective, we're in one area from the standpoint of a broader surveillance. Yeah, absolutely. We need to understand where it is. We need those sero surveys, which are going to tell us what people were doing and how we what has happened that we don't fully know about yet. We need all of that information to continue to inform the approach as we go forward.
Thank you, Dr. Richardson. And just one follow-up question on that is, so in high-risk environments like long-term care home, we've determined that we're going to test everybody. I believe that's all the staff and all the residents. As we're looking at reopening different businesses and restarting the economy, are we prioritizing different business sectors where some might be at higher risk and where we might want to prioritize testing? I'm thinking, for example, if I know meat packing plants have been identified as kind of a higher risk environment, manufacturing plants, anywhere that's allowed where people are talking to each other loudly in a confined space versus a construction worker who is outdoors and is more able to physically separate. So as we're working through the economic development and reopening portion of this, are we thinking about that testing and how to identify those cases in specific business sectors?
So through you, Mr. Mayor, this part of the approach to testing is part of what Dr. Dirk Heyer and Matt Anderson from Ontario Health are working out at a provincial level. And so we started to see elements of that strategy come out over the weekend with the Premier announcing about, asymptomatic testing and the continued expansion of it. But having that really good strategy is still something that we're waiting. The province is considering where would it be. So testing at this stage, it's opened up so people are able to access it, but we're still really encouraging that focus, or I shouldn't say the focus, but that absolutely this is the critical group that we need to come forward and get tested from a control perspective. Looking at how frequently might one do it in other settings in terms of mass testing, that's a bit one of the things they're trying to work out. Remembering that a test only tells you what's going on today. So if it takes up to 14 days after exposure. So even in our contacts, we're saying, well, what's the best day to test? Because if we test on day 2, well, they could still become infectious on day 14. Most people will become infectious or sick around day 5. So we're trying to understand where in the process is the best place to test, but always remembering that an asymptomatic person who has a test done, that just tells them their state as of today. These tests were designed for testing people who are sick to tell them whether that sickness was COVID. And so a screening test is also a little bit different than a diagnostic test. So all those refinements are being worked out, and we'll have a better sense of that as we go forward.
Thank you, Dr. Richardson. And it's interesting how we're all still learning as we move through this. So thank you for your hard work and your team as well, all the work that you do for our city.
All right, thank you. I had indicated that this was going to be the last one, but we had a last-minute jump in. So this is absolutely the last one. I'm not taking any more. Councillor Pauls, go ahead, and hopefully
it's going to be
covered a lot of
short
territory.
one. It's going to be
Sorry?
a short one. It's going to
Good.
be a short. I just want to thank you, Dr. Elizabeth Richardson. But I was just going to, how do we have a balanced response of the perspective of negative health impact of COVID? You had a chart there that said 3 million jobs are down, 20-30% of suicide risk up, 13% unemployment up, substance abuse up. So how do we do a great response to that chart?
So fortunately, we have people all around the world working on this because back to the however many $billion question in terms of how we manage this. There are people who have built their whole careers. Peter Sandman is Bart likes to talk about often. Who talk about understanding risk and balancing risk, and this is the dance that we are in together. And why, as understanding our values together as a society in terms of what risks are we going to take, what is okay, because life's not without risk. There is no zero risk. And right now, there's not going to be a world without COVID where we could go back to a whole set of risks that we were really comfortable with that related to traffic crashes and all those sorts of things, people getting heart disease and the implications of eating a lot of sugar and fat and all the things that were causing us risk before. That's why I say we're always living in a risky world. We were just pretty comfortable with the ones we had before. And now we have to understand both these particular risks and not have an epidemic of fear, but be mindful, deliberate in terms of how we go forward, calling on people to be mindful and deliberate in terms of what they're doing and the decisions they're making. And at the same time, very much understanding that we do need to have things get up and running. We do need to do those things because they're having negative impacts too. And this is why we need the input of so many people into this, of so many experts who are considering all the ranges. We need councils like yourselves. We need legislatures considering these issues and helping to say, where is the balance as we go forward? But that backbone of living with COVID and understanding it's in all of our hands in order to minimize these particular risks that we've done so well with and can continue to do well with.
Thank you.
Thank you.
And we want to minimize risks in all areas. So it's not one over the other. It's the broader impact of managing all of that as we go through. Doctor, thank you very much. And Jason, thank you very much. Thank you, councillors, for all of your questions. It is a significant issue, obviously. So we've allowed a lot of latitude, and we'll have a significant issue reported to us as well. Upcoming, I'm going to turn to a motion to receive the presentation, moved by Pearson, seconded by Danko. All in favor, we'll go right to a vote. And after that, I'll ask for a vote on the information report as well. Do we need any thumbs up? Everybody voted? Can't hear you. Haven't voted in a while. We've lost the flow. Did anyone vote against that? Thumbs up from Councilor Marula. Thank you. And thank you, and that's carried. And a vote on the information report as well. Moved by Councilor Pauls, seconded by Councilor Johnson. All in favor, electronic vote as well. And then we'll go to a break and be back here at 1:10. Councilor Marula, thumbs up one more time. Yes, thank you. That's carried. Motion to recess for that period of time. Moved by everybody, seconded by everybody. Partridge, Ferguson, I saw. Thank you. And we need an electronic vote at this. Nope. Oh, show of hands. Everybody's putting 2 hands up. Fantastic. We'll see you at 1:10. Thank you all.